Hi everyone, it's a great pleasure to welcome you all to the 9th European Tay-Sachs and Sandhoff Family Conference. Once again, we're having to hold this event online, mainly due to the COVID crisis, where we would normally try to hold our events in the springtime. However, this doesn't mean we can't hold a great event, and we have some wonderful speakers that are lined up for you all to hear from. So this year, we've decided to highlight some really important topics that we think are going to have a big impact on our community. The first of those will be focusing on clinical trial adherence and why that is so important. And the next topic for today is going to focus mainly upon access to information that can be found online. Tomorrow, we have our Science and Research Day, which was always a very interesting talk from different companies involved in GM2. I hope you can join us as well for that day. So before we start, just a few housekeeping rules. We have the whole event being recorded, and we will make that available via YouTube, so you can share that via different social media, and that's a way that can also be translated automatically with their creative caption functionality. Within the platform itself, you can see that we have the full agenda available if you go to the schedule, and this shows you who's speaking and what your speakers are talking about, and that covers all the different days we have planned. On top of that, it also highlights our sponsors, and we want to say a big thank you to Azafaros, JCR Pharmaceuticals and Sanofi for supporting this event and making it possible for us to hold this. As I mentioned before, this is the 9th year that we've been doing this event, and I think it's a testament to our community that we can all come together and support each other. You'll also notice that on the platform itself, you can add comments, you can ask questions, and there'll be polls also running. That can be found on the right-hand side of this platform. So please feel free to add your comments, ask questions, and it'll be great to get some feedback for the speakers so they can start answering those questions either during the panels, or if we have time for Q&As after each of their events and their speaking opportunities. So today, the first talk we're going to be giving is going to be focusing on who the ETSCC is. Now, I think it's really important for everyone to understand what we're about and why we were established all those years ago. At the time, I think, again, it's important for people to realize that there was no one providing any unified support across Europe back in 2012 when we were established. Now, to think that it was 10 years ago when we set this group up, it really shows how far we've come. The fact we have families from many different countries joining us today, and also many families who join us from different parts of the world. Because together we're trying to drive forward the research for Tay-Sachs and Sandhoff, so we can hopefully get some treatments to our patients as soon as possible. So I'll take you back to our consortium and who they are. We have 5 member charities. We're based in the UK, Spain, Germany, France, and Portugal. And together, we will work really hard to ensure that our families have their support. The biggest challenge we have within Europe is ensuring that we can get treatments to each person when they're available. We have to take into consideration that each country has its own laws, each country has its own languages, and work very hard to make sure the information that is shared is made in an easily accessible format for our patient community. That's something that unfortunately is always going to be a challenge for us in how the information is presented. And you'll hear from the different speakers we have planned today who will give you more of an overview on how that information is now being presented in a way that's accessible for everyone. So I think I want to take you back just to the very beginning to understand why we started. So back when we were established as a founding group of charities, we wanted to work with research because we knew we could help them move forward in their work. We wanted to raise awareness of Tay-Sachs and Sandhoff, not just within our own communities, but nationally and internationally as well. That to me is the most important part here, is because unfortunately, as these are rare diseases, some of our families don't have national support within their own country. What we're trying to do is ensure that these families can get support and advice on how to not only care for someone, but also get the relevant information for any particular studies that may be upcoming in the near future. And this is a slide I always show because I think it's really important for people to understand that many of these charities were started because lots of us were told, you probably won't meet another family affected by another family of a child affected by Tay-Sachs or Sandhoff. To be told this with your child in your arms is absolutely devastating. And collectively, we want to change that. We want to change the future for our families so they have this very intense support network who can help them on their journey. So how did it all start? I can take you back to our very first meeting, and this is Professor Cox, who's been involved with our group from the very beginning. We met in 2013 in Monza in Austria, actually, with only 4 families. And these 4 families all came together from different European countries because we wanted to improve how things were for each of us and our own communities. We could see the real impact we could have by working together. We could also see the impact we could have as a unified group. And that's why that first meeting in 2013 was so important, because it showed to us that it was possible. It was possible because our families were motivated and our families wanted to support one another. And why is that important? Because this is the sad reality for our families. And this is mine and my daughter, Amelie. So Amelie was inspiration for us to set up the CATS Foundation back in 2011. And as you can see, unfortunately, Tay-Sachs robbed her of her future. It took away all of her capabilities, which is a really sad thing to see as a parent. But in her memory, we are working along with other charity members to make a difference, because we wanted to feel part of a community. We wanted to feel part of something which we were told did not exist at the time. So I look at our strong community. I look at how amazing things have moved forward. So back in 2013 in Monza, there were 4 families, and we've grown year on year. We've held events in France, in Germany, England, and Spain, and every year more and more families have attended. And we now have this really strong community, which is working hard with each other as we drive forward, not only the research, but that support part of what we're trying to do. Because our goal is we want to save our families and want to ensure they have a future. And that's a goal that all of us are signed up to within the different countries. Now, I can show you again another slide from that first meeting. A lot has changed since this very first time in Monza. The community has grown, and it does continue to grow. And every year more people attend, and actually more people are attending our virtual events, which is fantastic to see. We're bringing all those key stakeholders together because we realized that as a group, we can bring the right people to the table. We can bring the charities, we can bring the researchers, the patients, the families, and also industry. And these people are really important because they're the ones who can drive forward all of those treatments that they're working on, which we hope will help our families in the future. And again, I think it's important for everyone to realize how dedicated we are as a community. We're dedicated as charities to keep providing support, but none of this would not be possible without you. Every family continues to inspire us in the work we're doing, and you have a guarantee from all of us that we are never going to give up until we can beat these diseases, because it's such an important thing we're trying to achieve. This collaborative approach we're taking internationally, and we're going to hear more about this as the conference goes on, has been key to that. And we've gone a long way in the last 10 years in how we work with the different stakeholders out there. And the question of why we do this is because we want to give hope. We want to give families something that many of us didn't have at the time of our child's diagnosis. Many of us were told, like we were, to go home and enjoy that time with the child, because sadly there's nothing that we can do. That's something we are absolutely determined to change for in the future. And why is that important? It's important because we need to have a solution for these devastating diseases. And we do this by bringing everyone together and having that community feel. And I just want to finish on this one really short video. And I think this is a testament to what our community is about. This was taken during one of our events we held in Disneyland Paris a few years ago. And it really shows how our community comes together, not just to hear these talks, not just to hear about the research, but just to be with one another. So that video, I think, is an absolutely beautiful moment that we all had together as a community. And I really hope that in next year and the future years, we'll be able to hold these conferences in person that can provide support to each other. So I just want to say once again, a big thank you to everyone who is attending the event over the next 2 days. And of course, to our sponsors, Sanofi, Azafaros and JCR Pharmaceuticals for making this possible. And I really, really hope you enjoy the next 2 days. So to move on to our next talker, I'm going to introduce Beatriz from ACTAYS. So Beatriz is going to give a really fascinating talk about the work they've been doing with supporting their families. So Beatriz, I'll hand it over to you.
Hello, everyone. Thank you, Daniel. Hi to everyone. I'm very glad to be here again at the 9th European Conference. I hope we can help you with anything during the conference. And now I'm going to talk about the topic we have selected for this year, the adherence to clinical trials, and how in ACTAYS we have helped in the way we can through our programs with this issue. And I would like to start this session by addressing what we've learned through experience and not only studying. That should be the main goal of a patient organization. The duty of a patient organization is to take care of affected families by the disease of one of their members. As it happens in most patient organizations, the parents or relatives of affected kids are the ones who set up an organization. This is, we can see this in the many of patient organizations around the world, because we know very good from the inside the complex and difficult journey that implies the life-limiting disease of a child. Many organizations, such as ACTAYS, has programs that deal with the humanization, let's say this way, of the health system. This implies not only to take care of families and the affected patients, but also to include into the equation how the health system treats family. How easy is or is not to deal with all the necessities. If are all these necessities that a family with an affected kid are covered, if to go through an hospitalization or if going through a surgery is an experience that really put that kid and that family at the center of the system. And the other main goal, of course, as patient organizations, is to contribute to the scientific research. This is something essential. That's why we are here today. We have corroborated with the researcher and the industry through the years how the role of a patient organization can speed up or boost a clinical trial. And here I go to my point. This is, thank you, Daniel. This is how we start ACTAYS, how we start the charity, being a mother with an affected kid at home, feeling that really the health system was not ready to attend all the necessities that start to come up through the months and through the years with our daughter. We founded ACTAYS in 2014, and we start reaching families abroad because of the prevalence. We were told that there were not more affected families in Spain. Then we discovered that there were just set up charity as CATS Foundation in the UK. Then we start to contact more families in Spain. And then I start to realize how these families have not the main, all the facilities we had living in the capital in Madrid. So that's why we start the charity, and we try to articulate our mission in different programs, not only to benefit our families, but only to help to the researchers. So back to the points, with these two goals in mind, to help affected families and to contribute to the scientific research. Here's where I go to my point in this session. That is, to contribute to the science must be compatible with the humanization of that system, the health system, or how everything works, how the patient and its family are really at the centers, how we took care of their mental health, their emotion, and not only their physical health, and also how we help them, their capability to cope with all the process of the disease. So based on this, one of our most complicated roles as a patient organization is to understand when a clinical trial is really an opportunity for that kid and when it is not, because this can happen, we have seen in the past. When the ethical reasons of, for example, using some kind of rules, as for example, the double-blind placebo control trial behind it are really justified or not, or when we must advocate for specific regulatory rules and about everything, when a family is ready and understands what it means to participate in a trial, that is nothing else than another step into a cure, but not always is the cure itself. So after years attending our families with a child affected by Tay-Sachs or Sandhoff disease through a program that has the aim of taking care of their mental health, developed by a specialized psychologist that works in our team, we understood that we have to give a further step with the families that were going to be involved in a clinical trial. And for that, we took into consideration how a clinical trial is seen by our families. And we realized that the clinical trials are considered by the patient to be very positive. They give them the hope of improving their quality of life and their individual pathology and allow them to give a positive significance to their adverse situation by contributing to scientific knowledge about the disease. However, it is also highly stressful because it means that sometimes you have to leave your place of residence, they have to leave their social environment, their culture, to go to travel to a different country, the reference environment for a few months to face the uncertainty of treatments with unknown procedures, side effects, and uncertain results. Also, in addition, we have seen that patients tend to have an ambivalent relationship with science and research, which they place sometimes in a position of omnipotence, to which they can go looking for magical or total solution, and it creates despair to know their limits. And of course, this has consequences for the patient and for the successful completion of the trial. It is a fertile ground for the appearance of maladaptive thought patterns or emotions, irrational ideas, the reappearance of past traumatic experience, and the reopening of grief, even if they have already been previously worked on by the subject. So therefore, it is normal that suffering and stress appears in the patient, and despite the initial commitment, there can appear moments of poor adherence to the treatment or even dropouts. These emotions we have seen are multiplied when the protagonist of the essay, of the trial, is a child, and his parents feel responsibility or guilt for his well-being. Communication with the child is indirect in these cases and passes through the interpretation of their parents, who may unconsciously project their insecurities into their child and increase the child's stress and anxiety. In this environment, all kinds of psychological discomfort can happen. For example, you can feel anxiety, loneliness, anguish, frustration, fear, uncertainty, lack of control, and all of this can lead parents to generate discomfort in their children, compromising with the optimal with their ultimate care of their children and damaging their attitude to the test or even abandoning it. So that's why an optimal state of mental health is required. If a life-limiting disease is a conflict for the emotional well-being of a mother or a father, imagine what is to see your child going through more tests, more doctors. So having the resources and tools to manage anxiety effectively, to an adequate coping and acceptance skills are essential for a correct adaptation to the trial situation, reducing discomfort and helping these families to better adhere to the trial. So for all this set of reasons, at ACTAYS we create a special program of psychological assistance during clinical trials that has different approaches, and you can change the slide, please, Dan, and have these different approaches and methodology depending on what special situation that family has, or who we are focusing, and different beneficiaries. As this is also a tool for the industry and the research teams, not only for the families, because we have understood that it's a team at the end of the process. It's a team that in where you have different players. You have the researchers, you have the industry, you have the family, and with the patient organization play a very important role in trying to make all these team players to go for the best results. So to sum up, and with this I end this session. At ACTAYS we have the aim to promote well-being and adaptive responses, to avoid all kinds of discomforts, and above all to avoid the abandon of trials, the dropouts for a family that is engaged in one. But above everything, for us at our core is that we are there to take care of our families, but in a realistic way, because we value their time, their effort, and their trust in all the players that are taking place into a trial, and we don't want to put that at risk. So that's why we consider that it's very important to prepare in a mental way a family that is going to take part in our clinical trials. Thank you very much, and of course I am open to any questions and to discussion this later with the rest of our guests in the panel discussions.
Cool. Thanks, Bea. They're really interesting. The question I have, do you think this is something other countries could also offer their families? And if so, is there a model that we could potentially all use?
Yes, absolutely. In fact, we create this program for a family and for a trial that was not in Spain, none of them. And thanks to the technology, we can be close to our families, and we can be close to the industry, and we can be close to the research. And we have found that it is very important to coordinate all these pieces, because the industry and the researchers have the obligation of put their main focus on the clinical trial, their safety, the results, their security, and we are the part that must engage with the family to put all our focus in that something really, really essential. That is, the family need to understand what is a clinical trial, and the family needs to understand that a clinical trial is not a cure. You are participating, at least in our diseases, the Tay-Sachs or Sandhoff. I know that in other diseases the reality is different, but in our diseases sometimes can be a help, sometimes can imply to improve their quality of life. But sometimes it is not going to be a cure, and it is not, maybe you don't, nothing improves in your child. And this is essential to understand from the families, that they have the opportunity to participate or not, and that it is important that they discover their mental strength to face the situation, because you have some families that their main goal through all the process of the disease is to be able to find that clinical trial and to be admitted in it. And you have to explain this family, hey, this is going to be a tough journey. And not always is, as I said, the omnipotence of the science. We have to explain that to the families that is part of the research. It's not the cure that you can buy in a pharmacy or that you can receive in a hospital. This is only part of the research, and you need to be very sure that you want to be part of the research, and that this is not going to be a solution for your family situation, a solution for your kid's health, but it's the legacy of your kid. You are going to be part of something bigger that will come years to come.
Cool. That's great. Thanks, Beer. Very interesting. I'm sure we have some follow-up questions as the event goes on. So I'm going to ask Toni to join us. So thank you very much, Beer. Toni is from Riemann-Pick UK. Toni is a good friend of mine, someone I've known for many years, is absolutely invaluable support to my family when we had our first diagnosis with Amelie, and she's been instrumental in helping us establish the CATS Foundation, but also using that model for the ETSCC. So I'm absolutely delighted Toni was able to join us today to talk about the real life challenges to adherence to clinical trial. So Toni, I'll hand it over to you, and and I'll share your slides for you now.
Many thanks, Dan, for those very kind words. Much appreciated, and thanks to you and the team behind this meeting for inviting me to speak today. Actually, that's my final slide, so I think we probably need to rewind a little bit. Thank you. Okay, if we could move to the next one, that would be great. And I'll start by just telling you a little bit about Riemann-Pick UK and who we are. NPUK is a national organisation, and we've been around for 31 years now, and we provide support, advice and information to patients and families who are affected by all of the Riemann-Pick diseases. Since our earliest beginnings, facilitating research and progress towards therapeutic interventions has been central to all that we do. And over the years, we've been able to develop strong relationships and networks across the world, enabling us to play a key role in many projects and collaborations, and more recently, to be actively and appropriately engaged in bringing clinical trials to the UK. And we could move on to the next stage, thanks. Thank you. But what are Riemann-Pick diseases? So Riemann-Pick diseases are actually a group of rare metabolic conditions that are pan-ethnic and affect all age groups. There are two recognised forms, ASMD Riemann-Pick diseases type A and B, and Riemann-Pick type C. Types A and B represent opposite ends of a spectrum of disease known as acid sphingomyelinase deficiency Riemann-Pick disease, or ASMD for short. Type A is a severe neurological disease that results in death, usually before the age of 4 years old. But in type B, there is generally little or no neurological involvement, and that means that patients can survive into their teens and adulthood, although not without experiencing progressing symptoms and challenging health issues. Riemann-Pick type C is a progressive neurological condition with a variable presentation and a range of complex symptoms, and it's very difficult to diagnose. Onset may occur at any time from infancy to adulthood, and life expectancy varies considerably. Moving on, thank you, Dan. We have many common challenges in rare diseases, and if your child is being diagnosed with any rare disease, one of the first questions you will ask is what treatments are available, what clinical trials are happening, what is being done to find a cure, or perhaps what is being done to prevent such diseases from happening in the future. My personal journey, I have lost 3 children to Riemann-Pick disease type C, has given me a true understanding of the challenges associated with rare diseases and also the impact upon patients, their families, society, and the economy. Rare diseases like ours are a global health concern and are in desperate need of new and meaningful therapies. Research in all of its forms, including clinical trials, are the only way that we will enhance understanding and achieve meaningful and effective and accessible therapies. Patient groups can play a major role in this process by working to positively influence the research that may lead to clinical trials and to support the design of such trials by representing the voice and needs of the community and by supporting patients and their families as they participate. Our aim is for patients to experience a better quality of life, quality and quantity. And this means we need to see the unmet medical needs of our community addressed, including those progressive and degenerative symptoms that are a feature of Niemann-Pick disease and Tay-Sachs. Next slide, please, Dan. In recognition of those unmet needs, our activities aim to stimulate and speed up progress. We understand that the challenges of therapy development in ultra-rare diseases are complex and will require cross-sectoral consultation, collaborative action, and considered effort to find appropriate solutions. And for this reason, supporting research remains central to everything that we do. We believe that as a well-developed and respected patient organisation, our voice is essential to the planning and development of successful clinical programmes in our disease area, and we're very happy to help in others too. And a successful programme with good adherence starts with the understanding of the patient community and understanding their unmet needs. To date, we have been able to play a key role in advocating on behalf of our community in the planning of multiple clinical trials, and we have found that having early and meaningful conversations with trial sponsors and appropriately informing our community helps to accurately represent the patient experience and to reduce downstream issues. Next slide, please, Dan. Within our small rare community, trials offer much needed hope for the future. The challenges and risks in designing and conducting clinical trials that will provide sufficient evidence to achieve approved status, of course, remains huge, not just for our condition, but for all rare diseases. It is very important to remember that clinical trials are research studies and that the products they are investigating are not yet proven to be safe or effective. They are just one stage of a long process to achieving an approved, effective, and accessible therapy. But of course, trials could not happen without the willingness of patients to participate. And adherence or compliance means attending trial visits as per the schedule, having all of the required procedures, reporting any adverse events, and any additional medications that you might need to take. Lots of patients, and for lots of different reasons, do not comply with clinical trials schedules. They miss their visits or procedures, they do not take their medication, or they don't report any adverse events or other medications. And non-compliance can really affect the outcome of trial, and therefore, considering the impact of trial procedures and investigations, the location and number of visits, and plus other practical issues such as travel time and time out of work and school is essential before you begin a trial. And so including that at the trial design stage is absolutely vital. If we could have the next slide, please, Dan. So where are we now for Niemann-Pick diseases? Well, we're greatly encouraged by the sheer amount of work and interest in our field at present. And when I joined NP UK 19 years ago, we could only dream of being in this position, but it does come with its challenges. And that challenge is that we've had many clinical trials coming along all at once. So all of the buses arrive at once, and then we have to figure out a way to cope with it. And not only do we have to cope with it as a patient organisation, we have to help our community to understand and to deal with it and make informed decisions. If we move on to the next slide, Dan, thank you. With the multiple competing clinical trials taking place and with more on the horizon, our capacity to support those participating and to inform our wider community, as well as to interact with those undertaking the trials, has been greatly challenging. Significant demands on our time, including additional community research, including quality of life studies, responding to requests from sponsors and patients and regulators, And regulators, of course, often require immediate and detailed responses, which can be incredibly challenging for a small team already working at full tilt. Our role as a patient organisation is to work with patients and families, as well as clinicians and sponsors, to manage expectations and to be able to provide clear and accurate information that will assist families in making the decisions that are right for them, particularly when faced with competing clinical trials. Representing the views of the patient community is a huge responsibility, and we take that very seriously. Not only do we ensure that the patient perspective and experience is recognised, but we work to encourage positive interactions between all parties and to ensure accountability of actions that will achieve the best possible outcome for our community. Social media is often the place that patients and families go to communicate about research, and this has its benefits and its drawbacks. It's great to be able to have such open and transparent discussions, but essential to ensure that the information shared is factual and does not impact upon the success of a trial. And there has always been a need for patient groups to use their voice on behalf of their community, but there is now a greater need for us to work together and to strategically raise awareness of the challenges faced by all rare disease patients, particularly in accessing clinical trials and later in securing access to safe and effective therapies. If I could have the next slide, please, Dan. So what about the patient and family perspective in our community? Well, I think most likely, like many others, the slow speed of research and clinical trials is a real frustration for our community. Time is always of the essence in Niemann-Pick diseases in a progressive and life-limiting condition. As well as the work being undertaken by industry, there are many individuals and groups in our community who have, over many years, raised countless millions working towards finding effective treatments for these diseases. And none of this would have happened without the huge contributions and sacrifices of the many patients and families who have waited many years for these trials to come around. Their participation in clinical trials has been vital, and it really does help to further the understanding of our condition and to understand whether therapies actually work. But because of the competing nature of the clinical trials in our community, many have felt confused by the difficult choices in front of them. And despite their wish to be involved and make a difference, not just for their family, but for others, they've struggled with the decision to be involved. A key challenge for us has been trying to manage their expectations, especially when there are multiple options, and to provide clear and accurate information for them to take away and to discuss with their health professionals about whether it's right for them. Being enrolled in a clinical trial also brings practical and emotional challenges for families who will juggle school, home, work, life, and these may present barriers to participation also. Our aim is to ensure that everyone has the opportunity to find out about trials and what is involved and to realistically know what to expect. We want them to ask questions, to speak to their healthcare team and to us, and to make whatever decision is right for their family. The next slide, please, Dan. Some of the family experiences that we have had, as I've said, include competing trials. With a small population, it's very difficult. We only have 130 Niemann-Pick type C families, for instance, in the UK. And with 3 trials running at once, there's not very many people to go around. And of course, you have to consider the trial criteria and what's right for people at each stage of their condition. There are few centres available in the UK with limited capacity of how many families they can take. So some people have long distances to travel. And that can involve very long days, overnight stays, and then, of course, invasive procedures and the many research studies and forms that you have to complete as part of a clinical trial. In some cases in our community, we've had clinical research organisations who are in charge of booking travel to trial centres or supporting expense claims. And this has been problematic as they often don't understand the needs of the families or they don't reimburse claims in a speedy manner, and that can cause an issue when families are missing work. We have been able to pick up on those issues, and as a patient organisation, we can offer to support that if the sponsor is willing to allow us to do that. The disruption to home, school and work life, as I mentioned earlier, can be intense, and that can impact upon family relationships and also on the finances of the family. So it's important for a patient organisation to know what help might be available to support them in that. And of course, there's the emotional side. It's very difficult. We all want to consider these things to be a cure or to be an actual treatment, when in fact it is a research study and we don't know what the outcome will be. And then in our case, there has been 2 trials that one has failed. It is classed as a failed trial, and the other has got through to approval stage and been refused. So we have had some disappointing times, and we have had to pick up the pieces for families. And also that has led us to understand the better ways of communicating, and also how we can advise sponsors to communicate when these issues occur. And my final slide, Dan, thank you. So just a few key messages here, really. The clear communication is absolutely essential, to manage community expectations, and making sure you're sharing the appropriate information and educational resources that perhaps explain the drug development process and the stages of a clinical trial, the process of approval and reimbursement, and why all of these things take so long. There are many benefits for patients in having those early conversations, and also in communicating clearly. Especially, patients feel much better and more included when you are communicating what's happening with them, and that can be, reporting results of a study that they've been involved in, if it's possible to do so, or just simply saying, this trial is continuing and we really appreciate your participation, and we want to hear what your thoughts are about your experience so far. Also, I think it's great for patients and families to understand how much their efforts are appreciated by others in the community, and how their participation in trials may improve the future for others. There is also, when you have these early conversations, there's a potential decrease in the burden of participating in clinical trials, because people will actually understand what's important to patients and families, and what can really help them on their journey through a trial. And these benefits are not just for patients, they're for sponsors, for the clinical sites and the investigators too. And of course, we also have to think about, the industry and community interaction. And again, I come back to those issues that we've had, and to make sure that we encourage appropriate, timely communications that go out to those that are participating, but also to the wider community. And of course, these are impacted by trial compliance, and that's legal compliance as opposed to adherence to a trial. So I think that, the final message there is that the participation of patients in trials is absolutely vital for progress. But as patient organisations and as sponsors, we all have a duty to ensure that their experience is the best it possibly can be, and that we all want to see the positive outcomes for our families. Thank you.
Thank you, Toni. It's a very interesting talk as always, and to hear how far you guys have gone in your journey with companies to get treatments. We're obviously still very early stages, but all the things that we can learn, your experiences, what worked, what didn't work, where we can really have a bigger impact as an advocacy group, I think is absolutely vital. Really say a big thank you for sharing all of that with us today. And if anyone has any questions, again, please put them in the Q&A. Toni will be coming back to one of our panel discussions very shortly. So thank you, Toni.
Thank you.
Cool. So the next speaker we have is Riliang from Sanofi. Hi there. So Riliang's going to give us a talk about the industry's involvement and adherence to clinical trials. So I'm going to get your presentation up, and I'll hand over to you to carry on. Thank you.
Thank you, Dan. Good morning, good afternoon, good evening. Hello, everyone. This is Riliang Zheng. I'm a clinical research director at Sanofi. And today I'm on behalf of Isabella Bastu, our global project head, to present the industry perspective to adherence to clinical trials. Next slide, please. So when we talk about clinical studies, clinical trials, there's always a question, why a clinical trial or clinical studies conducted, right? So to answer this question, first of all, clinical trials are essential to develop new treatment, because whenever one investigational drug coming from a laboratory, we need to show and need to provide the benefit, to demonstrate that this investigational drug can provide benefit to patients. And how can this be demonstrated? That's we need the clinical trials to show how the drugs work and how the patients tolerate the drugs. And also, the last but not the least, before any investigational drugs can be prescribed by the physicians to the patient, it is mandatory to obtain approval from the health authorities. And how the health authorities to evaluate investigational drugs, that all through the clinical trials to collect the data and to show the effectiveness and the safety of the investigational drugs, and to get the final approval, and then get the treatment to the patient. Next slide. As we know the reason why the clinical trials are conducted, and then how the clinical trials going to benefit the patients, right? So when a series of clinical trials demonstrate that the investigational drug can work for the disease, and also it's safe for the patients to take, it opens the way to a new treatment option. And at individual level, when you participate in a clinical trial, it's offer you an opportunity to potentially receive a newest investigational drug that may help the treatment of your disease, especially, for rare disease, right? Usually there's no other treatment options there. So clinical trial provide you an opportunity to access to investigational drugs may help. And also when you participate in a clinical trial, you can get additional care and attention from the clinical trial staff. And plus, to the benefits to individual, to a broader community, it helps the community of the patient with the same condition, right? By moving forward the knowledge of the disease, and also potentially advancing the new treatments. That's not only benefit at individual level, and it's also kind of a potential benefit for the whole community. Next slide, please. And then how do clinical trials work? So all the clinical trials must follow a set of rules that called good clinical practices. And these rules are very rigid standards and clearly guide what medical professionals can do or cannot do during clinical trial. And the top of these rules is to make sure to ensure the patient's safety during their participating in the clinical trials. And also, all the clinical trials follow strict procedures designed to help the researchers to determine the safety and effectiveness of the investigational drug or the medical treatment being studied. That means all the clinical trials, they have the protocols predefined, have all the procedures designed, and then after that, we have to follow that strictly to make sure all the data collected through the clinical trials are consistent and within a good quality, and to make sure the data package valid for the final approval for a new treatment to benefit the patients. Next slide, please. So as we know that all the clinical trials need patients' engagement, and you're essential in the key to success in the clinical trials. Without patients' participation, there's no way we can achieve a new treatment to benefit the community in the future. Next slide. So when the the study, when the clinical trial start, the study compliance is crucial, because when patients miss visits, it reduces the amount of information and the data collection, which causes the missing data. And the missing data make it really hard to draw valid conclusions about effectiveness and safety of a study drug or investigational drug. And the missing data may have the following important impacts as listed here. And first of all, as making it impossible to demonstrate the efficacy of the study drug, even though, when there is a difference in the response of patients on the study treatment and the patients on placebo. For example, usually we're going to have a clinical performance scale to evaluate your clinical manifestation, right? When you participate in a clinical trial, there's some assessment to evaluate how you are performed during the study. For example, if we have to evaluate your balance, right? We may have a scale from 0 to 5. The 5 probably stands for the best case, and then there's no issue of your balance, and the 0 probably you lost the balance totally. And then when you follow the study schedule and get the assessment, get the test done, we have an accurate score of your performance, and then that may be 4 or 5, right? But if you miss that visit, we must assume the worst case of that, and that we're going to have a 0 score instead of accurate 5. So that jeopardize the efficacy analysis for sure. And also, when the amount of missing data is high, that's going to invalidate the study results. Every clinical trial, before it starts, they're going to have an assumption as how much data we need and how many patients we need to achieve a valid data to show the efficacy of the investigational drug. So if the amount of the missing data is high, then the data package won't be sufficient or enough to support the evaluation of the efficacy or safety of a study drug. So that's going to invalidate the study results. And as we mentioned before, the conclusions from the analysis will be presented to the health authorities to get approval, right? And these agencies will use these data to decide whether or not to approve the study drug as a treatment. When the high rate of the missing data and jeopardize the integrity of the study and jeopardize the integrity of the data package, that may cause unsuccessful approval, and that's going to delay or even destroy the possibility of a really effective drug to reach the disease community. So that's why we say the study compliance is crucial when the study starts. So when you participate in the trial, adherence to the study and follow the study schedule is very, very important. Next slide, please. And as a sponsor, from the sponsor perspective, just want to highlight that your study team is always here to support you. We are here to commit to providing you with the best experience possible. Even between visits, you are not on site. Don't hesitate to reach out to a study team when you have any questions, concerns, any difficult to coordinate your travel to site, any other aspects of study participation challenging to you. Don't hesitate. The study team is always there to support you and work on our best to figure out a way to easy and smooth your experience there. And if you have any questions and want to understand more about the post-study access to the study drugs, there are always different programs there to provide you the access. And anything else in your mind, don't hesitate to reach out. As I mentioned, from sponsor perspective, we will always have the study team here to support you. And the resources are available to help you to make the best decision for yourself, for your health. And also keep in mind that you're always free to stop the study, but just, to remind you, it's very important to inform the study doctor before stopping or modifying your treatment. If you are considering leaving the study for any reason, contact your study doctor, your study team, ask the questions, and we can, discuss together to figure out the best decision for you. Next slide, please. And here is a roadmap of opportunities that we have already began to travel. And we say that patient's insight and feedback is fundamental. And we have the patient insight in kind of early involved into the protocol optimization and help us to reduce the patient's burden. And we provide a continuously support. At the very beginning, when we start to develop the investigational drugs, develop a new treatment, the patient's insight always help us to find the right direction. The research always oriented by patient's insight. And the real world evidence driven development can be more and more involved. And also for the formulation, we always consider the patient's preference for that, and to make the administration of the drugs easier for you. And also, from the protocol optimization, we always put the patients first. That's the patient-centric protocol design. We want to hear from you, kind of what's the most meaningful things to you during to improve during your disease, during your clinical trials, and capture your insights to support the trial recruitment and adherence, to hear what's the barriers, what's the burden there, and how we can help. And to reduce the burden, we have the direct patient supply that shape the study drugs directly to your home, have the remote visits set up to reduce the burden from travel. And we also have the personalized reimbursement system in place to provide flexibility when you need to, be on site visit. And continuously support, we have the education through the remote technologies, including apps, social media, and we have the patients advocacy groups involved, like today, to get feedback from patient, and also we have the adherence and compliance programs in place to support and maintain the patients on the study. Next slide, please. And here is the package of the patient's adherence and compliance supportive materials. We have a thank you letters to show our appreciation for your participating in clinical trials. We have a periodic study newsletters to update you the study status. We also sharing the study progress with the patient advocacy groups to make sure the transparency and share the study progressions for the whole community there. And if you are interested in the scientific background of the clinical trials, we have that information available for you. And also we have material to explain how important to keep compliance and adherence to the clinical trials. And then also we closely follow up on patient status, collect patients' feedback, and address the questions on a timely manner to make sure the patients have the best experience during the clinical trials. And thank you all for whom participated in clinical trials or plan to participate in clinical trials, because we know that it's really time consuming and really need your commitment there. And that's a lot, we really appreciate it as a sponsor and from industry perspective. And without you participation, there won't be new treatment or medications available in the future for the whole community. And thank you all. I think that's the end of my slides. Thank you for your attention.
No, thank you. That's really interesting. And I know that Sanofi have done an awful lot of work in the past few years on patient centricity, working much more closely with the advocacy groups to make sure that we can get the messages out that you're working on to families. And it's great that you're able to join us today to give the industry perspective, because I think our families really need to hear it's not just us talking about it, it's also you guys in industry. So I really appreciate you coming along. And I know there's going to be questions that come in, so I will direct those to yourself or to Isabella over the next few days. So thank you once again. And
thank you, Dan. Thank you, everyone.
No worries. Cool. And I'm going to bring on our next speaker. So our next speaker is Alex from Cognitant. So Alex is a good friend of mine and has a very, very interesting project to talk about, but also about how education can play such a key role in adherence to clinical trials. So Alex, I'll hand over to you on the slides. I'm really looking forward to this.
Brilliant. Thanks so much, Dan. Thanks for inviting me to talk. Yes, I'm Alex Merckx. I'm the Director of Marketing and Partnerships at Cognitant. And as Dan said, he's asked me to take a bit of time to explain the work that we've been doing with Azafaros and ACTAYS, CATS, the NTSAD Association, and the Cure GM1 Foundation, to help to educate people about the Pronto Natural History Study to support recruitment and adherence to this study. So if you move on to the next slide, Dan, I'm just going to start by giving a bit of background for anyone who doesn't yet know about this study. So Pronto stands for the Prospective Neurological Disease Trajectory Study, which is quite a mouthful, hence us calling it Pronto. And it's a natural history study that will follow children who have or are at risk of developing GM1 and GM2 gangliosidosis. So the study will be run by Azafaros and will follow 60 to 200 patients in Brazil, Germany, and Spain for 5 years. And that's in collaboration with ACTAYS, CATS, NTSAD, and the GM1 Cure Foundation. So just moving to the next slide. As you've been hearing from all the previous talks, recruiting participants to take part in natural history studies can be really challenging. And that's particularly true in the case of rare disease communities, where there are often lower sample sizes to recruit from, as you can imagine. And then there's the challenge of people staying on the trials or the studies once they've started. So obviously motivation to participate in a study is key as a starting point. And it can be really difficult for patients and their families to be motivated to participate in a study or to stick to it. And particularly if there's a lack of information shared about the study up front. So people really need to understand the aim of a study, what's involved, the positive reasons for participation, etc., just as has been discussed. So Azafaros approached us to see if we could help to overcome some of those challenges of recruiting children for this particular study, as well as helping to support adherence to the study. So the aim was really to empower people with all the information that they might need about Pronto to help raise their awareness of the study and to help families and caregivers have all the information that they need to take the decision about whether they were interested in participating. So how did we go about approaching this? So if you go to the next slide, Dan. So we followed a co-creation approach, which this slide is attempting to demonstrate. And this is an approach that we always take when we're developing educational programs. So we brought together key stakeholders, which included all the patient advisory groups that I've mentioned already, caregivers, families, and clinicians from Europe and the US. And the group was, they were included in a series of virtual co-creation workshops with the aim to design an educational program for Pronto. So during the discovery workshop, the group discussed things like what the curriculum should cover and which formats should be used to maximize the impact of the education. which is really important. And then we went on to defining the program a little bit more and developing it further through to delivery. And the stakeholders were included throughout that whole process. So the end result, if you flick to the next slide, Dan, is that we've created a patient and family-led educational program that sits on a resource hub online. And it's a collection of clear and visual material with a lot of animations that talks through all the various elements involved in Pronto. And it includes information on what the Pronto study is, what participation will entail, which is really important. They need to know what to expect, how the various assessments and tests work, and the purposes of them, and the key reasons that might motivate people to participate. And the program's available in English, Italian, German, French, and Portuguese, Brazilian. So if you flick to the next slide, Dan, the idea is that clinicians, researchers, advocacy groups and families can send this content directly to families and caregivers and enable them to view and share the digital content away from the clinic and in their own time, which we think is really important. It's important that people can consume the information in the comfort of their own home rather than having to spend more time in hospitals. So Dan, I think there's a video for you to play just so that people get a feel for what the content looks like.
In this short video, you'll learn more about the SARA assessment used in the Pronto study. People with GM1 or GM2 often can't walk or talk easily due to a condition called ataxia. The SARA tool can help researchers understand more about how GM1 and GM2 affects a person's movement and how this changes over time. SARA assessments consist of 8 activities. Examples of these activities involve asking your child to walk heel to toe, speak, and to place their finger on their nose. The assessments take around 30 minutes to 1 hour to complete. They're done at home during a virtual assessment with the study doctor. Your child will need to complete SARA assessments every 1 to 3 months during the first year of Pronto, and every 6 months thereafter. The answers collected may help researchers understand more about how GM1 and GM2 affects movement and coordination over time.
So hopefully that gives you a flavour of some of the content that's included in our resource hub. And just a final point on how we're measuring the impact. So the impact of the program's being assessed through patient feedback and engagement metrics. And what we've seen in the first 3 months since project launch is that over 250 individual users have accessed the resource, and they're spending on average about 7 minutes and 30 seconds consuming the content, which we're really pleased with because we think that indicates that users are engaging with it for a good amount of time, which hopefully means that the material's useful. So just to finish off, we're really thrilled to have had the opportunity to develop this tool with Azafaros and our patient advocacy partners. And we hope that it's playing a small part in delivering a really successful Pronto study for your community. So thank you.
Cool. Thank you, Alex. That's really interesting to give the overview of that project. And I know as advocacy groups, we're delighted to be involved in it, to actually have our voice listened to, because I think many of us will know it's regularly told that advocacy will be involved, but sometimes we're kind of shunted to one side. So to actually have the opportunity to really contribute to something as worthwhile as this, I think has been really exciting. We hope it could be a model that potentially can be used with other companies developing studies, because I think the patient voice has become more and more important. So it's brilliant. So thank you for that.
Thank you.
Cool. So we're now going to move on to our panel. So I'm going to invite our speakers to come back. So I'm going to bring back Toni. Hello, Toni. Bea, nice to see you. And Diana has joined us all the way from America to join this panel this morning for her. And the plan of today is we want to talk about, very briefly, why it's such a challenge for trial adherence and how collectively we could make that easier for patients and their families. And I think this is something that's going to be really, really important. So I've got a few questions that I'm going to give out to our panelists as we go along. But please drop them into the Q&A session. We'll try to get through them as we can. So I think I'm going to start with Diana because we haven't heard from her yet since she's joined. Obviously, you can say hello to everyone and introduce a little bit more about your background for those who don't know you. Although you were the winner of the NORD Advocacy Award this year, weren't you, for the length of service at NTSAD? So.
Yeah, well, hi, everyone. I'll be talking later, so I'll do the introductions. But good morning, good afternoon.
So I think, so this one's for you, Diana. So in your experience, how big an issue is adherence to clinical trials? What have you seen over the years for us?
Well, trials are pretty new for our community. So I think the big thing from what I'm seeing is what was talked about earlier, is showing up for those follow-up visits. I think that's really important, that compliance that was mentioned earlier, really important in keeping the data going and consistent. And I think making the decision to participate in the trial as well, or even a natural history study, just really following through and thinking about things, as Bea had mentioned earlier. Sort of there's a lot of emotion. It's a logistical roller coaster when you think about a trial. So
that's cool. Thank you. So Bea, for your families, what do they say about this issue? Is it anything you've talked about a lot in terms of clinical trial adherence with your Spanish-based families?
Each family is a different universe. So we focus on treating them separately. At the beginning of our programs, back in our psychological program, back in 2017, I think, or even earlier, 2016, we made a lot of meetings in Spain, in Madrid, or in the European conferences. We had these meetings with all the families. We focus a lot on research and everything. And through the years, we start to understand that we have to approach this family separately because they have different interests and different understanding and different culture about research and science in general. So we try to first meet a family, know them, know how well informed are them about the disease or not. You find a lot of families that go back to home with the diagnosis and with the doctor's advice that don't waste your energy, there are no treatments for this disease. And that they take this and they lack into this frustrating prognosis. And you find other families that set up as charities, as you and me. So I think that it is very important to focus on each family separately, to get to know them and to be able to understand what information they need. So we like to do this with each one of them because some of them doesn't really need a lot of information, just to check with you. Or is it true that this clinical trial has already started? Okay, I have read everything and I know my kid can go or whatever. And they have an amazing set mind. But other families really doesn't understand what is a clinical trial. Many families think that they are safe if they go to a clinical trials. And that's when you start to manage expectation. And that's a huge responsibility for us. That's our main concern with our families.
Well, thank you, Bea. Very interesting. I think, Toni, we've touched on before, there's quite a lot of similarities across our two communities. And there's actually a question that came in on the from someone, which was that there's obviously a lot that we can learn from your experiences. What's the number one thing you think we should, take on board that you encountered in relation to this topic that you wish you knew before?
Well, I think first and foremost, I would say that, like us, your communities well, and you're able to advocate on their behalf at a very high level. And, for us, I think it was around the communication of what's happening in clinical trials before a trial even starts, introducing, the company and the prospect of this trial happening and making sure that people are aware. And that the consistent messaging, as was just mentioned within the last session, of those updates from the sponsor, wherever it's possible. We understand that there is compliance, but just saying we're still here, we're progressing this trial, we're making progress, and keeping people informed. And that doesn't just include the wider community, but it's incredibly important to communicate with those who are participating in the trial and with the clinical centres, because we have found that in some cases, the patient organisation or social media are aware of something before the clinical centres and the trial participants. And it's really key that does not happen. I think it's good practice to communicate first and foremost with those people, and to make sure that people feel informed about what's happening in the trial. So that's a key takeaway for me.
Okay, very interesting. Thanks, Toni. It brings me on to a question for Alex, actually. So I know that Cognitant's worked in the rare disease space, in the chronic space, and the more common conditions with adults and children. Have you guys seen a shift in the expectations that families want in terms of how information is presented to them?
Yeah, I think so. I mean, we're seeing a shift in a sort of general increased expectation from people to be really well informed about anything relating to their health, which I suppose is just to be expected, really. We're used to having information at our fingertips even, for example, from Google. But of course, Google, you have to be a little bit careful with the misinformation you might come across. But that's the culture that we have now, to feel that we're well informed. So there's definitely an increased expectation to be more informed, and for the information to be provided in plain language, in their language of choice, and that the information is provided in a really accessible way, whatever that means to them, because of course people have different needs in terms of accessibility. So often people will say that they have a preference for visual formats, which is often logical, because we know that the brain processes information 60,000 times faster with visual formats, such as video rather than text. But also, people are sort of stating more their preferences in terms of their learning preferences, and saying, actually, we need to have information provided in a range of formats to suit different learning needs and preferences. So yeah, there's a definite shift.
That's very interesting. I think I know Diana and I last year actually gave the talk about this, where how information when families were diagnosed with GM2 has changed dramatically in the 10 years that I've been in this kind of area, and Diana's 25 plus years, which is absolutely fascinating. So question for you, Diana, then is, do you think families are really expecting information overload now? And do you think there's a learning on how we can make sure they get the right information on this sort of topic?
Definitely. I think that I find that we've been listening more to the community, listening to how they ask questions, what they want from us, what information they're looking for, and how they want it. So we try to educate our community in different ways, like Alex was talking about, some visual, just bite-sized pieces. And then also letting families know too that they can come to us and not have to wait for us to give it to them. They can come to us and ask for it. So I think that's shifted, instead of just throwing everything at them.
That's interesting. I think at CATS we've seen that, where families would be more proactive than when we went through the diagnosis journey, we kind of sat back and were expecting, you know, that the information would be sent to us, and it may come in a week, in 2 weeks, in 3 months. And I do think families are much more proactive, which I think is fantastic. And our whole mission is to get the signposting right. And I know you're going to be talking about that later with Emma, which is really going to be interesting for people to hear. So from a question for Toni then, in terms of your experiences on this topic of information, how it's shared, what do you think is really important for your community that's transferable for us in the GM2 space?
I think a lot of the things that Alex said about the method of communication and making sure you've got different mediums of communication available to families. Everyone interacts in different ways, and we all have to embrace all of those different ways. And don't forget that some people are not on social channels and require a letter still. So there are lots of different things that I think you can do to support that, but also having focus groups and that ongoing educational side about the phases of clinical trials and what happens after the clinical trials. And those things are really important too.
That's really interesting. I think that's something we just need to really consider. And I think from your experience, Alex, at Cognitant, have you seen this shift in expectations of families? Do you think that people are being given information all the time in the right format, or is there more that we can do on an advocacy level?
I mean, I don't think there's enough information for people so far. I mean, I can just say from a personal point of view that I have 2 sons who were involved in clinical trials recently, and we weren't given that much information, and we weren't given any information about the protocol and what to expect in terms of participation. I think it's really important to provide as much information as possible upfront in plain language about what the study's aim is, what's involved, how it can benefit them and their community, etc., etc. And the role that the patient and the advocacy groups have in that is really key, because it goes back to what we were saying earlier, working out the right information that's going to be provided and the right formats that should be provided in needs to be guided by the audience for which it's designed. So, we need to think about what are the formats that will help that particular community. Are the particular participants' needs? Do they have visual or hearing impairment? Are there the emotional and aspects that we need to consider, like Bea was referring to earlier? Is there a need for sort of real short bite-sized information for a particular reason? Should the information be designed for the patient or for the caregiver? So all that information we can't know without talking to the patients and the advisory groups.
No, very interesting. I think that actually touches on a topic, Bea, that we could be here all day talking about, which is about culture and languages. And we obviously have this it's not an issue, but we're all from very different cultures in Europe. So when we're trying to create materials and develop studies, we have to be very aware that the cultural differences can play a part. What's your view on this, and how do you think we could overcome it in this sort of topic?
I think that what Alex said is essential. And I feel that there is a lack of coordination when a clinical trial is going to start, because you have the industry really struggling to provide the exact information to the patient, but they don't always have the patient view, although they think in the patient, but they don't always incorporate the advocacy groups, and that's very frustrating sometimes for us, because we as patient organization spend a lot of time trying to approach to the industry, trying to let them know that we want to coordinate, and it's like we haven't reached the level to be considered another key team player for this. So I to participate in the Pronto study was really my first experience in this, and our first experience as a group, because we didn't have the chance in the past to be there for the industry and to say, hey, I've been there in that position as a mother, and I know that this is very important for you, but let me share the point of view of a mother who is struggling, who is full of information. Many times we don't understand that to be full of information is just to understand each symptom. And you have tons of information there. And as Diana also said, we have been for many years sending a lot of information to the families. And now we understand that we have to rationalize that. So that's also part of our key role, as Alex was saying.
That's great. No, thank you very much, everyone. That's a really interesting discussion to have had, because I think it touches on many different points for us to consider, not just in clinical trial adherence and how we can work on ensuring that that's addressed properly, but on a wider picture of terms of information and how it's presented back to people. So we're just on time now to have our breaks. We've got a break for 10 minutes before we move on to our next topic. So I just want to say thank you to all of our speakers in the session earlier. And obviously, thank you to Alex, Toni, Beer, and Diana for joining us for the panel. And I'll leave you all now for 10 minutes to go grab a cup of tea or a cup of coffee, and we'll reconvene in 10 minutes. So thank you very much, everyone.
Thanks, Diana.
Thanks.
Hi everyone, it's great to be back here now for the next session. I'm really excited to be introducing Gisela, who's going to give you an overview about her role as a patient advocacy manager in an industry partner. And this is going to touch upon that role and what they have to do and how they interact with us in the advocacy side. So I'm really excited to hand over to you, Gisela. You just need to close the other browser, Gisela, that you have open with the conference. Can you just close it because we get the feedback? In an industry partner. And this is going to touch upon, just close the other browser for us. In the advocacy side. Gisela, that you have open. Because we get the feedback. Do you have that closed? Oh, I think Gisela will just probably log back in, but just while she's just doing that. So this talk is going to be really interesting because one of the questions that we get asked by our families is who are our contacts within our industry partners? What is their role and how do we communicate with them? And we're very fortunate that lots of our companies now have dedicated advocacy managers. And they are really bridging that gap between the patients, the patient organizations, on their delivering all of their work towards their studies. So the talk that Gisela will be giving very shortly when she joins us again will be focusing on how her role was developed over the years, because Gisela's been working in patient advocacy for quite a few years at different companies, and how she's also seen that evolve over time. So whilst we just wait for Gisela, who is back now.
Can you hear me? I'm sorry for that. I don't know what went wrong.
No worries. No problem. So great to have you back. I've just given you a nice introduction. So I'm going to get your slides up. And as usual, just ask me to next slide and I'll hand it over to you. Thank you.
Okay. Thank you so much, Dan. And thank you for the opportunity to speak. So my name is Gisela Linthorst. I'm the head of patient engagement at Azafaros. Next slide. And although we heard already a lot of people talking about the importance of patient engagement, probably I will make some repetition of that, but I think this is where it all starts. If you want to know the drugs, you have to understand the disease. And if you want to understand the disease, you really have to understand the patient. And in my opinion, working with the community and with the patients makes you aware on the impact and on what is really important for the patient. Next slide, please. So what is in-company patient advocacy? I will touch upon why it exists, what it entails, and how it's done. Next slide. So I don't think I need to explain to you what advocacy means, but because you're all advocates for your own disease and for your own child or for your own community. But I think patient engagement is more increasingly in the last, or did increase more in the last years. So advocacy exists, raising the voice for patients and carers in healthcare related issue is already happening in 1920 in all sorts of ways. So in hospitals, in schools, or in families. But there was a long time it was more done without real visibility. And then in the 80s, 90s, it started really with the HIV movement to accelerate and to be more important. Since the 90s, the FDA developed involved in for the first time patients in advisory boards and in their organization or more in their decisions. Not with a lot of patients, but it started and it's developing more and more. So I think there was also a realization at that time for patient groups that they needed to be better informed or better organized to make really the difference for their own community. It started also to be more professional, so interacting then with companies, because companies also realized that that an adaptation was necessary. And so with the regulation of, for example, the FPA code, it became more professional. It became more a two-way partnership, and people companies and patients felt much more comfortable to interact with each other. And at the moment, policymakers request input for patients. And since April this year, the International Council for Harmonization of Technical Requirements really demand now the influence and the involvement of patients in the development of the new studies and clinical studies. Next slide. So this is mainly a repetition. So what's the impact? The impact is working with patient organizations throughout the process. It delivers much better outcomes for patients in healthcare systems and society as a whole. And so companies learn that the input and the collaboration is important. The legislators learn that it's important and request involvement. And ICH made a decision this year, as said before. Next slide. So one of the things, development in advocacy or in the companies, let's say, so companies understood how important it was. And then so a lot of companies hired in the last 10 years in rare disease mainly, so it's also in other companies, but in rare disease it's something of the last 20 years, let's say, that there are dedicated people in companies who work with the patient community. So an in-company patient advocate is really the bridge between the company and the patient community by closing the gap. So an advocate is working with patient, parents, advocacy groups, but also the broader community in closing the gap and ensuring that the company drug development and the supportive programs during and after development reflect the need of the patient community. Short term, so during the development, but also after launch, and long term. Next slide. So probably you came across already some patient advocacy or patient engagement colleagues of mine. It sits in different places in companies. It's called medical affairs, or it's under medical affairs, or public affairs, or communication. And it has different titles: patient care, patient relations, engagement, public affairs, or partnerships teams even. It's sometimes one person and sometimes it's a whole dedicated team, which is a very nice development, let's say, in the bigger organizations. Next slide. So before I explain what we are doing as patient in-company patient advocates, it's important to know that with new legislation, there are formal and informal principles of patient advocacy. So we follow the guidelines from example, the FPIA code, which is the code how to work with industry and the patient community, but also local rules. So every country, in Europe you have so many countries with different rules, so every country has their own regulation set, and company SOPs where you also explain what the compliance rules or how to work with patients in a compliant way. It's always about listening, learning from patients and caregivers to understand their life experience and to see where both communities, or the company and the community, can benefit. A company needs to build a framework, which means it has to find ways to in a transparent way work with patient organizations, following the rules, but also with the correct behavior and interaction. Both parties are responsible for meaningful, transparent collaboration. So it's not only the company who's responsible, but it's also the patient organization who needs to work also in a transparent way, not only one-dimensional, but it's always about collaborating together for the same benefit. It's a two-way street, and it's not only funding, but it's also learning from each other, setting up projects, and it's, like I said, beyond development and launch. it has to be, so patient, there are a lot of companies who say that they are patient-centric, which I think most of them are, but it's more than only a mission statement or a picture on the wall. You really have to build it in the structure of the company and deliver on what you promise. And I think it's really the time now that it's not only nice to have a patient advocate or a patient-centric organization. It's not nice to have only, it's a need to have, in my opinion. Next slide. So where does it sit? It sits, or what is important, that it's a cross-functional incorporating role. So it's with working with, so the patient sits in the middle, and in this slide, I put patient advocacy in the middle, but it's more to show that you're next to the patient and really working together with your colleagues and other departments to set up really patient-centric or patient-focused clinical trials or other supportive projects. You work with them, they help you, and I help them, or an advocate helps them, and the patient helps us to understand what is important for us. And like the other speaker of this afternoon already said, it's key that clinical drug development is that the outcome is really something the patient needs, and that's why it's so important to have an early involvement of patients in clinical development. Next slide. So there are multiple things what a patient advocate needs to do in a company, but it starts to setting the standard for the company culture and commitment by keeping the team mindful on what we do and for who we do it. So you develop a deeper understanding with the team where they are coming from by, for example, inviting patients or patient speakers and let them hear the patient's story, arranging opportunities to be more involved in what the patient is going through. Support and root for the integration of patient insights in phases of element of the whole development. Support the data collection together with your colleagues, and also developing a strategy together to include the patient perspective in the study design. Next slide. And a patient advocate, in company patient advocate works also obviously with external to groups and external to patient and parents. Although we are in Europe not allowed to work directly with patients, in the US it's a little bit easier. There is a difference between working towards or supporting groups or supporting patients. So if you work with groups, obviously it's important that you are informing those groups, involving them in the in the activities of your organization, and finding together supportive collaborative programs and initiatives that benefit organizations and communications and the individuals. You also, next to that, you work directly with the groups. There are also societies and federations in a broader way where you can work with them to influence the legislation and the policy changes in a later stage. And also important is to support the empowerment of patient organizations, to see what they need and where you can help next to funding, but also maybe to raise awareness and set up collaborative projects. External to patients is mainly also be sure that you inform the patient in the right way. We discussed this afternoon, the Pronto studies. You have to be aware that we as a company and also organizations, that we are obliged and have a role in providing the correct information about our studies, about the disease if it's not existing, all these kinds of helping to manage the expectations also about the drug development process is very important. Next slide. So working with groups worldwide is important because every group is different, every culture is different, and as an advocate, you have the opportunity to deep dive into really the needs per culture, per organization, and per patient community. Next slide. So why is it so important that, and I think this morning it was already stretched, or this afternoon, is that early engagement with patient associations in clinical development is really key. So by explaining already your plans and your study, you can also activate their engagement in setting up focus groups, etc. Share with them what you're planning to do. Share your clinical, your draft clinical study design. Discuss with them on several stages if it's something the community needs. As an advocate, so patient advocates, they can be the advocates in the company to be sure that the patient is involved in all these all these phases, which I'm described here on the slide. I won't go into every detail, but I think if you involve the patient in an early stage, you can always make some changes, you can explain it better, the patient organizations can explain why certain studies are developed as they are, because they were taken with them in the development of the study. And you see that in every phase of the clinical study development, it's very important that you take the community with you as a company before market access, but also after market access. And we spoke about adherence before. So adherence at every stage is important. So you discuss also with your groups where you can integrate, maybe by e-health or by other, by social media, etc. Where can you integrate tools? What it makes for the patient easier also to access clinical studies. How can a patient be best adherent, not only by the e-health, but also by traveling, make it as easy as possible for a patient to be adherent or to participate in clinical studies, as discussed before. Next slide. So I think the Pronto study it's already discussed, but it's mainly that you're obliged as a company to provide understandable in lay terms information. And it's for now for the National History Study, but it's also for other clinical studies, but also for your informed consent. If a patient doesn't understand what the study is, I think we can work with groups, but also patients can tell us what is needed and how it's best explained. And having a role in the company who can develop the whole process to it, I think you can get the better information on that. Next slide. Raising awareness together with groups. This is a video for the Riemann-Pick community during the Riemann-Pick Awareness Month and Day. And together with the Riemann-Pick UK patient organization, we developed this video. It will be a series of video where you raise awareness for the disease. So it's something in-company patient advocacy can play a big role in. We know that patient groups are doing a great job, but you can always support them and help them to develop or to bring some other aspects into it. Next slide. Also, not only working with the dedicated patient organizations, but working together with industry and bigger federations can benefit the patient community in a accelerated way, let's say. So it can accelerate the treatment, it can accelerate also the thinking, but also the whole, how do you say that? The whole, so that it's after or before launch already crucial for patients. I cannot find the word, but that there is something in place where, for example, newborn screening is also important to have. And working with industry partners, and we do this in collaborative and we do this in consortium, you work together with collecting data. For example, you could do this together instead of everybody does it for themselves, or developing a patient-reported outcome. So as companies can work together with their advocates, they can develop a structure around only the product, let's say. Next slide. So it's not to pat us on the back, but it's more to show that it's important that you, as a company, involve patients very, very early, and that the company, and that's what I mean with putting the structure in, that the company involves patient advocates or medical teams in an early stage already, so that the patient is from the beginning to the end a really crucial part in your drug development. This was my last slide.
Great, thank you, Gisela. Very interesting as always, and I think as someone put into the chat to hear that about the internal advocacy role and how actually important it is in our kind of communication. I think that lots of families won't be so aware how much work we all do together with you and people like you in your role at the different companies, and you're always banging the drum for the patient centricity, putting the patient first, and without you would be a very different space, I think. So from our perspective, we would say thank you for all the work you do for our community to make sure that we can keep developing things to support them. So thank you.
Thank you.
Cool. Okay. So our next speakers, I'm going to be introducing Diana from NTSAD and Emma from the CATS Foundation. Now, these two are going to be talking to us about navigating information online. So from the experiences they have from both a advocacy perspective, but also from a personal parent perspective. I think this is going to be really interesting for everyone to hear how things have developed over the years, but actually how there's much more work for us to do. And it's not an easily solvable thing out there. So I'll hand over to Diana and Emma to get started. Thank you.
Great. Thank you, Dan. It's been an interesting morning so far. I've already learned quite a bit. But thank you for the invitation to speak alongside Emma today. It's good to see you, Emma. I know I can speak on behalf of NTSAD to say that it's been wonderful to collaborate with you all and the others over the years, and I'm most excited to participate in today's program and watch the rest of the conference from the little state of Rhode Island, where it's cold and windy today. For those who don't know me, I'm Diana Pangonis, Director of Family Services for NTSAD. Like Dan said earlier, I've been with NTSAD for nearly 27 years. Actually, next week is my 27-year anniversary. And I've seen how much has changed and how far we've come in all that time, especially in the last few years. So my job alongside Becky, who's our Family Services Manager, is to be there for families to offer support as they learn about navigating the world of rare disease, symptom management, the complexities of care, exploring the latest in research and clinical trials, and also through bereavement. It's the best job. I wish I didn't have to exist. Next slide. So NTSAD stands for National Tay-Sachs and Allied Diseases Association. In the beginning, we were considered an umbrella organization for all lysosomal and leukodystrophy disorders. However, today we focus our research and family support efforts on Tay-Sachs, Canavan, GM1, and Sandhoff diseases. Advancing research, partnering with other patient advocacy groups and industry, fostering collaboration, and supporting families and adults is at the heart of everything we do. Being a part of this European Family Conference is one of the many ways we love to collaborate with our partners, as we all have the goal to see effective treatments come to fruition for children and adults in the future while supporting families today. So today, Dan invited me to speak about how families access information that is reliable about the diseases that affect our community, the research, and the clinical trials. I hope what I share today empowers families in their quest for information. Next slide. So after a diagnosis, as many of you know, 1,000,001 questions are asked, seemingly all at the same time. What is Tay-Sachs? What is Sandhoff? What are we supposed to do now? How did this happen? Are we the only ones? Is there a cure? Is there a treatment? And what do most of us do when we don't know something? We grab our phones and turn to Google. The problem is that Google gives you everything all at once, which is scary and overwhelming. How do you even begin to sort through all the noise that's whirling around on your screen? And who and where do you turn to? Next slide. A good place to turn to are the organizations that understand the diseases inside and out. As Bea mentioned earlier, all have been founded by parents who are experienced, have been where you are, and they get it. Each organization has the resources to understand what the diseases are, how to manage symptoms, what the latest news is regarding research and trials, ways in which your voice can be heard, and how to connect to other families who are experienced in managing these diagnoses. The organizations also know how and where to find the answers you may be seeking, including, next slide, is there a cure? This is the question that has been asked for many, many, many years. Again, we all turn to Google to scour the internet for any sign of hope that there is a cure, a magic elixir that will make everything better, especially the prognosis of these diseases. But the abundance of information, good and bad, is also overwhelming and confusing. So then, who and what do you believe? Next slide. Like was mentioned earlier, the patient advocacy organizations around the world, like these here, are reliable sources of information, or at the very least, a conduit to the right information. A terrific resource also are the YouTube channels for some of the organizations here. There's a wealth of information and past presentations from conferences and webinars that are informative and enlightening. I think that can be underused quite a bit, and there's a lot on there. We also have materials that explain what is a clinical trial, what's involved in taking part in a clinical trial or a natural history study, the importance of participating in all of those. How do you balance your expectations and hope? And why does the process take so long, among many other topics? And I do want to remind you, to everyone that's watching, if you have questions, do not hesitate to reach out to any one of the groups. We're here to help you find the answers. We're connected to the companies. Like with Gisela, we speak to them often. We know how to get the answers for you. So I definitely encourage you to do that. Next slide. There are other reliable sources of information in addition to our own websites that are educational as well. And I'm just going to highlight two here. ASGCT, which stands for the American Society of Gene and Cell Therapy. They have many videos and some really good resources about Tay-Sachs and Sandhoff, about gene therapy and cell therapy. And we have partnered with them in the last couple of years, creating material specifically for the diseases that have ongoing trials. So that's a really great resource. And then another one is Courageous Parents Network. They help families and healthcare providers understand the path a family takes when faced with a life-limiting diagnosis. Their clinical trial pathway for families and providers is outstanding and sheds light on the many issues, questions, and concerns that arise when considering a clinical trial. They're curated videos that help you feel, to help you know that you're not alone, and you can hear other parents talking about their journeys in any one of these topics, along with many others. So I definitely encourage you to check them out as well. Next slide. So in the quest for information about clinical trials, there are a couple of places you can learn more about the specifics. Clinicaltrials.gov, as shown here, is a US-based site run by the US National Library of Medicine of the NIH, National Institutes of Health, where you can search for clinical trials, past and present. You can see which ones are enrolling, which are not enrolling, which are on hold or paused. The listings will share information about the trial, the criteria for enrollment. Some will list the endpoints that will be measured during the trial and where the trial sites are based. It will also include the contact information for the trial sites, and they're really the ones who can answer more specific questions. And I do want to remind everyone, because it does come up occasionally, that groups like ours and even company patient advocacy teams, they have no influence when it comes to trial enrollment. The people that make those decisions are the principal investigators or the PIs of the clinical trial site. So I just wanted to add that in there. Next slide. And here is the European counterpart to clinicaltrials.gov is the EU Clinical Trials Register that is run by the European Medicines Agency. So that's another source to look and do a search on clinical trials. Next slide. Lastly, it is frustrating that there aren't enough clinical trials or approved treatments today for our community, but there are so many ways to be involved. And I encourage you all to think about that. In the several focus groups that I've been a part of over the years, I find that someone, including myself, always learns something new from the conversation. So I encourage you to find ways to participate, whether it's a focus group, a natural history study, attending a conference in person, or a virtual meeting like this one. Next slide. And before I hand it over to Emma, I'd like to remind families that, again, if you have a question or in doubt about information you're seeing, reach out to any one of us. We're all working together to ensure families get the right information when they need it. So thank you, Dan.
Thanks, Diana. Thank you. So I'm just going to talk a little bit about the initial diagnosis time, really, and where you go from the doctor's office or wherever you've been to being told what's going on. I work, my name's Emma Murphy. I work with the CATS Foundation as a family support officer, and I'm also mum to a little boy who had Tay-Sachs disease. I feel that patient organisations like ourselves, who work specifically with these diseases, are vital, like a vital starting point for newly diagnosed families to access accurate and reliable information. Not only do we have the ability to direct families to factual information, we all have very personal reasons for doing the work that we do. This supports not just the actual factual information that you crave at that initial diagnosis, but it's always the support that comes from a place of real understanding that hopefully gives families that sense that they're not on their own, that we can introduce them to other families, and that there's a whole community out there living a life that's similar, that they can be put into contact with. I think the words rare disease are it's a very it gives you an instant feeling of isolation, as well as all the other huge emotions you have at that point when you're told your child has a Tay-Sachs or Sandhoff disease. It's a big a huge thing. And I think when Stanley was diagnosed, we were given a sheet of paper that had been printed off the internet, which I'd already read all of this information beforehand, before I actually knew the diagnosis for sure, but I'd kind of figured it out by that point from my own sort of research and things. And yeah, so what was given to us was nothing more than I'd learnt myself, and I couldn't gain any information. Nobody was sure. I think at that point I was told Stanley would possibly have 6 months to live, which was pretty inaccurate and very, very frightening. Yeah, so that was quite scary. And I think until I came home and messaged Dan at the CATS Foundation, I think I went through the website. I'd found them beforehand, but I didn't know if Stanley had Tay-Sachs or Sandhoff. Once I found out that we were looking at Tay-Sachs or Sandhoff disease, just depending on one more genetic test, one more blood test that had been done that day. Yeah, so I messaged Dan and through the website and got an instant reply back. And we've got, I'll go through this a bit later on when we're having a talk, but yeah, it was, yeah, we found the email the other day, and it was a very emotional email to read, and it just reminds you of how vulnerable and desperate you are in that moment, and how much you need to know things, and you need the right information as well before you start going off on a whole other roller coaster that you really don't need at that time. Yeah, so I think I think it's important that the right professionals who have access to these families initially, they have the initial contact straight after diagnosis, know about us and know to refer to us or refer the families through, and let them know that we're here, so we can start supporting families with all their questions, all their emotional needs, everything that's needed at such a devastating time, rather than not the doctors' metabolic teams not even being able to give very straight or accurate answers, because they don't deal with these diseases all the time, they're rare. It's nice, yeah, for them to then be passed on to us so that they don't have to navigate this whole world of information that's not always accurate. Yeah, and can do a lot of harm sometimes.
That's great. Thanks, Emma. And I know we're going to touch on it in the panel, but when we were going through the emails, revisiting that diagnosis journey for you, it was a very different experience for us as it was for you. And I'm just so glad that there was someone there in terms of the charity who could provide that support. So thank you, Diana and Emma, for a really interesting talk. I also think it's fascinating to see how things have been developing continuously. Not every year things have changed and how the charities support people. And I think it's important for, again, everyone to hear how much work that everyone is doing behind the scenes so we can keep improving that level of support we give to families. So I know you're both going to be joining us at the panel shortly. So I'll let you drop off for now, and then I'll introduce our next speaker. So I want to say a big welcome to Rebecca Stewart from the Rare Revolution magazine. So Rebecca's going to give a really interesting talk about the work they've been doing in the rare disease space. I don't want to ruin anything, so you can give a surprise. I'll get your slides up and hand over to you.
Thank you. Thanks, Dan, and thank you so much for allowing me to be part of the conference today. It's really special to be here to kind of be able to talk to you all. So over the next 10-15 minutes, I'm just going to talk to you about why we are passionate about writing for rare diseases and why we felt the need to start an information revolution, and to kind of go through and explain some of our experiences that have shaped our approach to disease awareness, education, sharing lived stories, and what we're doing to lead in responsible journalism. So as Dan said, my name is Rebecca Stewart, and alongside my partner in crime and sister, we are the co-founders of Rare Revolution magazine, and also the Rare Youth Revolution. And so if we can go to the next slide, we're going to start though right at the very beginning. So for those of you that don't know us, I'm going to give you a quick potted history on how we got to where we are. So these two cheeky chaps here, the one on the left is my dad, who has the rare disease, chronic inflammatory demyelinating polyneuropathy. And he was diagnosed with that in his 20s. So we grew up around rare disease, although we didn't really realise it then. We always referred to dad and his wobbly legs and occasionally required hospital holidays, but we didn't really appreciate what rare diseases were, and what the extent of rare diseases or the community. And it wasn't until 2012 when my nephew Edison was diagnosed with a completely separate rare disease, xeroderma pigmentosum, in the February of 2012. Two completely separate diseases, one with no genetic basis, and one which is a recessive genetic disease. So I think that in itself is kind of demonstrates the real extent of rare diseases. You know, we think of them as rare, but really they're not. And Edison is, as we describe him, the boy that started a revolution. And it was really when he was born that that embarked for myself and my sister Nicola our kind of change of direction and change of career into rare diseases. And the next slide will show you where we kind of started. So back in 2012, 2 days after Edison was diagnosed, we put together the plan for a not-for-profit support group, which was called at the time Teddington Trust. It's now become Action for XP. And as part of that support group, what we wanted to do, which Nicola identified very early on, was look at resources. Now at 13 months, we all know what it's like trying to keep a hat and some winter gloves on a toddler. And you can see here from some of these photographs, our families with XP cannot be exposed to ultraviolet radiation. So you can imagine the challenges of keeping hats on and visors on very young children. And there were just no materials that could help parents talk to children about their disease in a way that they could understand. And so Nicola had started telling Edison these stories about a character called Little Ted, because Ted was his nickname. And so that ended up being our very first project for Teddington Trust, was to create this series of, it turned out to be 6 stories, and to create an actual little bear as a dedicated resource for young people with XP. What we didn't know at the time was just how valuable resources were, good resources were. And what we discovered over the years that we've run that project is that not only was this resource good for parents talking to young children about their condition, but it also became a tool for peer-to-peer support. Children could talk to their friends about it. They could talk to their classmates about rare disease and about XP without talking about themselves, because they could talk about Little Ted. They could show people the hat and visor. The clinic also found it a really useful tool, so they were able to use it. But it also demonstrated representation. You know, children were mirrored. They could see something that was like them, somebody that represented what they were. And that feeling of confidence that they weren't alone, even in the bear, was really, really powerful. And that really started our passion for rare disease resources. Now, as part of that, as any charity does, of course, we all want to raise awareness for rare diseases, and we were no exception. And we were fortunate quite early on to have a good article in a local newspaper up here in the northeast of Scotland. Now, we were given front page placement, which we thought, this is great. However, what we weren't prepared for was what would happen to the story next. And what happened was that story kind of goes into the press pool, and then other newspapers and other news outlets picked it up. But they don't come back to you for a re-interview or for more information. They just rewrite the story as they see fit. And so we ended up with this digital footprint, which went from, you know, the US all the way through to Korea, with lots of photographs being lifted off of Nicola's private Facebook page and then marked as copyright of the journalists. There was very little and sometimes no mention of the charity whatsoever. So we ended up with this huge digital footprint for our toddler and virtually no benefit for the charity as such, whatever. And it made us think, well, have we just been unlucky, or does this happen elsewhere? And of course, what we found was that our own families, within our own families, many of them had tried to do a similar thing and had found that they'd been, treated not as they would want to be. And as we started exploring into the wider rare disease community, we found the problem was huge. So I'm going to apologise in advance for this next slide, because some of the headlines you'll see here will be a little bit upsetting to some of the families. But as we've got a multi-stakeholder audience here today, I thought it might be a really good learning point, especially for those that are thinking around communications. These are all genuine headlines, not all from tabloids. You will see some of them are from health editors and some of them were from the broadsheets. And you can see how upsetting these sorts of headings are. In some cases, the articles were genuinely quite good, but you can see in terms of rare disease awareness and setting back the public perception of rare diseases, these are quite damaging. And not only from an individual disease point of view, there's a couple here that I wanted to point out that were devices even within the kind of patient community. We've got one here, the cost of drugs for rare diseases is threatening the US healthcare system. Obviously a really damaging and divisive headline amongst, everybody that needs hospital care. So it was really things like this that made us think we want to be the absolute opposite of this, and how can we do it? And so somebody said to us, well, if these sort of publications don't exist, maybe you should try something yourself. So in 2016, we had this idea that we would start a Facebook page and see if we could create a quarterly newsletter. So we did launch the Facebook page and we were completely overwhelmed with how many people responded and wanted to get in touch. And so our newsletter actually ended up as a 54-page magazine. And on the next slide, you'll just see some of the examples of some of the front covers that we've got there. Over the last 6.5 years, we've gone on to produce a quarterly core editions, special editions, build a website, and the role that Nicola and I are playing is to build a reliable and a reliable source of information. So something that is dependable, that isn't sensational, and that anybody who wants to talk to their lived experience and share their stories with us will feel that when that publishes, it's something that they can be proud of. It's something that they've had a really positive experience of. But of course, the stories are not ours, they're yours. And whilst we write them on your behalf, sometimes, we couldn't, the success of Rare Revolution and what it means to people and how it is viewed across stakeholders is down to people being willing to share their stories. And whether that's as family members and individuals, or, from the scientific, the healthcare, and also the pharmaceutical and biotech industry, it's that sharing of your experiences that makes it so valuable and so powerful. The other thing that we wanted to be able to do was to support charities in getting their information out there. As Dan mentioned, we'll talk about it a bit more in the panel, but charities have really become a great source of reliable information. But they don't always have the bandwidth and the resources and the budget to get that promoted as widely as they could do, not only just for reaching families, but for reaching healthcare providers and other people and companies and organizations that might become partners of the future. And so we wanted to provide this place that talked about what charities did and the conversations that they wanted to have, rather than it always having to be about a human story, which of course is what the press are always looking for. And so in doing that, we could really effectively signpost and share the successes and the challenges and the work that's being done by an incredible community. The other thing that was really important to us was building a cross-condition rare community. And of course, as we've gone on, we've seen this in much bigger situations with the Rare Disease Day campaign and the kind of rare as many mantra. But I do think it is really important, as communities important to you all. We understand, though, that when diseases are very small in numbers, you might not have someone next door to you or in your local area that you can just go and get that cup of tea with. And so, of course, by building a cross-condition rare community, we can increase the chances of peer-to-peer support, both locally and globally. And then, of course, the responsible journalism part of things, which is something that we're really passionate about, ensuring that people are using the right language, sensitive language. And one of the things that we do is everything that comes into us is edited for our house standards, whether it's come from a company as a corporate piece or a communications company. If we don't like the tone of the language, we will correct it and send it back. And for us, those are teaching moments to help improve the quality and the standard and the sensitivity of writing right across the board. But one of the other things that we're trying to achieve with this is to provide a sense of hope. And Dan mentioned it in his opening talk. It's really important. And the more we work with pharma, the more that we realize that, of course, for them, hope is like a swear word. They're absolutely terrified by it. And if ever we're doing sponsored pieces where pharma has to review the work that's going out, they will try and remove every last vestige of hope for fear that, of course, by providing hope, we're giving false hope or false promises of treatments that are to come. And I suppose my message to them is that we can't, not to confuse their view of hope with the view of the community. Of course, yes, we're all looking forward to a time where we have more effective treatments and that we can get past only 5% of rare diseases having a licensed treatment. But also hope is found in finding a community. Hope is found in just knowing people are working on your disease or researching your disease. And so to be, if I could say again to any of the industry people that are watching today, don't be as terrified of hope as I think you might be at the moment, because the opposite of hope is hopelessness. And if all we leave in communication is a sense of hopelessness, then why are we doing it? So let's just remember that hope comes in all sorts of guises, and this is one of the reasons that we exist, and that we hope that people find hope in the fact that there is somebody interested in talking about reason and sharing their stories, and that in itself gives them something to be a bit more hopeful for. Now, of course, we cannot do it on our own, and this next slide will show you just how our team has grown over the last 6 years. So that's myself and my sister up in the top left corner there. And I love this picture because it pretty much sums up what it is like working together most days. People often say, oh, what's it like working with your sister? And I'm very lucky because we've got an incredible relationship, and we are the yin to the yang. What one can do, the other can't. And so we complement each other very well. So for the first 2 years of Rare Revolution, it was really just the two of us. And then David, who's in the middle on the bottom of that row on the photo next to us, was our very first employee. Soon followed by Emma on his right, and then Becky on his left. And then more recently, we've had Jeff and Joe join us. And below, we've got Chelsea and Katie, who together lead up the Rare Youth Revolution, who are supporting what we do on the main magazine but for young people with rare diseases. And so really, this is the team. There's just 9 of us, and what we're all completely dedicated to is bringing about a dramatic and wide-reaching change in conditions and attitudes for the rare community. That's why we're here. We're here for you to be able to share your stories and to share the work that you're doing. And so we have a very open door policy. And while we're kind of on the subject of people, the next slide will just show, and again, Diana and Emma spoke very eloquently about this, is the benefit of a wider rare disease community. for all the wrong reasons. None of us really want to be here, but it is an incredibly vibrant space full of really incredible people. And we feel very fortunate to work in this community, both on an advocacy level and through the magazine. And one of the things we did, which I'm very proud of, is build this cross-community condition. And our Rare Revolutionaries group, it's a closed Facebook group for patients, families, caregivers, and advocacy, those working in advocacy, to connect with each other. And I'm really proud to say that we've connected a number of people from across different diseases who have become friends, who travel to conferences together. And I think that's something that we can all benefit from. When we first set up Action for XP, we were very focused on that XP community. And it wasn't until we stepped outside of that, we were really able to benefit from other people's experiences, whether it was just finding a platform to host a virtual conference, or whether it was to find materials to understand more about clinical trials. There's so much great work out there that we don't need to replicate, that might just need a little tweak for our community rather than recreating everything again. So I think being part of that wider community, both on a family level, but also on a kind of advocacy support level, can be really beneficial to us all, and give us that extra support in what otherwise is, a very isolating and challenging environment. So I think take advantage of those friendships that you can make, both within your own disease communities, but also as part of the wider group. And we're very lucky to work with all these cheery chaps and meet them at conferences. It's a real highlight for me when we're out and about, is the friendships I've made through this that I wouldn't have done otherwise. So that, I think, is everything from me. I think the next slide just has my details on there. If you would like to get in touch, we're very welcome to hear from you all. Like I said, it's an open door policy. I hope that has given you a little flavour of what we do at Rare Revolution and the Rare Youth Revolution. Thank you again very much for having me, Dan. And I'm looking forward to following the rest of the conference.
Thanks, Rebecca. Really interesting. We've done a few articles for the magazine over the years, and we always enjoyed the work and sharing the work that we've been doing with you guys as well. So it was really interesting. I'm sure people know they can visit your booth in the expo. They want to get more information or to read some of the past issues. So thank you very much. So I'm now going to introduce our final speaker before we move on to the last session of the day, which is the panel, which is Maria from EURORIDS. Hello, Maria. How are you?
Hello, Dan. Can you hear me?
Yes, we can hear you.
Okay,
very good.
Great.
So I'm going to hand over straight to you so you can give a presentation. Okay. You can introduce what you're talking about. So thank you very much.
Thank you, Daniel, for this introduction and for the invitation. So my name is Maria Cavaller, and I work for EURORIDS, the Rare Disease Europe, and I joined EURORIDS 4 years ago. I'm a pharmacist by training, and my role is as patient engagement and therapeutic development senior manager. I'm involved in engaging patients in regulatory activities and also in another European initiatives, in other projects. So next slide, please. So EURORIDS, for the ones who are not aware about our organization, is a non-for-profit organization, and our main vision is that all people living with rare disease can live longer and better lives, meaning that they are recognized as equal citizens and they have their fully rights respected, that they are timely and accurately diagnosed, and that they are cured when possible, and if not, that they have the support of the best medical and social care, and that are included in the society in the whole aspects of life, and they live independently. Next slide, please. So here are some numbers and statistics that you might know. So there's 30 million people living in Europe with a rare disease, 300 million over the whole world. And in EURORIDS, we have 1,000 members, and we represent more than 70 countries in Europe, but also abroad. So, next slide. So our main strategy, we work having patients' needs in the center, and we have 3 main pillars. And one is empowering patients, and we do that through training. We advocate also for the patients' rights through the main stakeholders, and also we partner and we engage patients within different stakeholders. Next slide. So we bring patients' voice into decision makings within different stakeholders, and the first one is within the European Medicines Agency, and that's the one that I will focus today in my presentation. But we also bring patients into early dialogues with payers through a pilot called Mechanism of Coordinated Access to Orphan Medicinal Products, or maybe you have heard MOCA. Also with HTA, with the Health Technology Assessment Bodies through EUNETA. With the developers and companies, we do that. We engage patients through the EURORIDS community advisory boards. And also we engage patients with clinicians through the European reference networks and the European Patient Advocacy groups, the EPACs. And also in research with the European Joint Program on Rare Diseases. And now we are getting into the digital health as well. So we work within all these stakeholders and we bring patients' voice into decision making. So today, as I mentioned, I will focus on this first column with our engagement within the regulatory agency with the EMA. So before that, I would like to hear about you and to know more who is in the audience. And Daniel kindly prepare a poll here for you. So I think you just need to go to the right in the bottom or a tab called polls. So I would like to know if have you ever heard about the European Medicines Agency? I'm not sure if you are there in the poll, but you should see the poll tab on the right, and then you can answer it. I'm not sure then if people can see it. You will let me know, I guess. So I wanted to know more or less if you have heard about the EMA and also if you have been invited to participate in any activity. So I'm not sure if this is working. If not, we can go back to the slides and maybe we can discuss this afterwards. And
the polls are there. If everyone just goes to the polls tab. Maria, you just carry on because they appear automatically. You can't see them when you are.
Okay, so you will. Okay, so next slide. So as mentioned, we will focus on how is patient engagement at the European Medicines Agency. So the EMA was created in 1995, and since the start, they were engaging patients and starting this dialogue. So in 2000, patients became committee members, meaning they had the full right vote as other member states in the committee. And it first started with the Committee of Orphan Medicinal Products. And actually our CEO, Jan Lekam, was vice chair of the committee, and we've been always involved. And now I'm also involved in this committee. But then afterwards, other committees had patient representatives. So now we have patient representatives with full right to vote in the Committee of Orphan Medicinal Products, also in the PRAC, the Pharmacovigilance Committee, the Committee of Advanced Therapies, CAT, and the Pediatric Committee, PDCO. And then also other activities at the EMA were coming up, such as scientific advice in 2008, so patients were involved, and then a well-established framework was presented in 2005 that has been evolved during these years. Also the Patient and Consumer Working Group in 2006, and a whole patient public engagement department was created in 2014. So other activities have been ongoing until now. And next slide. And today we will focus on the one that is in red circle, that is called scientific advice. So patients are involved at the EMA within different activities, within different formats in committees, like as the ones that I mentioned, that you can see here the acronyms in the blue circles. But they are involved since the beginning when the product is in development, also during the evaluation when the EMA is assessing before marketing authorization, and also after authorization, what we call post-authorization activities. So here you can see the different steps and where patients are involved. And today we will focus on the scientific advice. Next slide. So for you to understand what we will be discussing in the next slides and what it means, scientific advice is an advice request by the developers, so the companies that are developing a drug, to the EMA, and usually they ask questions on the clinical development. And this scientific advice can be at any stage, so very early in the development or during the evaluation. And also we involve patients in in this advice. So they give advice to the company regarding their clinical trial development. And you will see in the next slides that I might refer as protocol assistance, because that is when is assigned for an orphan designation. So it's a regulatory term, but it's the same type of advice. It's an advice of a company, but for protocol assistant is for orphan medicines that have an orphan designation. So if we move to this next slide. So EURORIDS' role in these procedures where we engage patients at the EMA is to help the agency to identify patients and involve them in this procedure. So we involve patients in this so-called protocol assistance, which are the ones who are for orphan drugs designated. And we help them to identify patients through our membership. So as mentioned, EURORIDS has more than 1,000 members. So we help them and we check our membership to identify patient experts. We also check our database and also the EMA eligible organizations. Also patients that has participated in the past. Sometimes when we cannot find a patient, we also go through Orphanet. So we have several resources, and once we identified patients or a patient, how we select them. And so basically we select patients that have experience with the disease themselves, so as a patient or as a carer. Also, we engage patients who have an ability to read and speak English, because of course all the documents and all the exchanges are in English, and with a certain level of medicines development. So we don't expect patients to be scientific experts on their disease, but we want patients that they bring the added value of living with the disease. They know the needs of their community. They also know how the disease is clinically managed, and also what are the unmet needs on their disease and what is expected from the innovative therapies that they are coming. So basically, another point that is here highlighted, and I always highlight it, is in the free from conflict. So meaning that usually we cannot involve patients who have been involved with the developer, in this case, who is asking advice to the company. But this I'll explain more in detail in my following slides. So next. So once we have identified this patient, once we have selected based on this criteria that I just mentioned, we start this process of the whole involvement. So we help the patient to complete this declaration of interest and also the confidentiality agreement. We also explain the policy. And as I mentioned, for scientific advice concretely, the declaration of interest and the conflict of interest policy is a bit restrictive, let's say. So we check the last 3 years of your interaction. So from day one, like today, 1st of December, 3 years back, we ask you to declare within which companies you have been exchanging with, if you have any financial interest and another interest. So you will declare that, then the EMA will assess against this policy, and then if you don't have any conflict of interest declared, you can get started and with the involvement. So then you receive the dossier, so meaning that the questions that the company has asked the EMA. So you receive basically the same documents that the regulators receive. There's no lay summaries for patients, and that's what we have asked a lot to the EMA to provide this support, because there's a lot of technical terms, but for now you receive the same documents. That's why EURORIDS and also the EMA Public Engagement Department are helping you through this process to understand what is needed. So once you are identified and you are into the process, you also ask the EMA, you are asked to have a call with the EMA scientific officer in charge of this procedure, and they help you through the questions, also to let you know where to focus, usually in the clinical questions. So and the endpoints, and I will go more in detail on my next slide. But you are involved in these questions, and then you can meet the company either by writing or in a TC. Nowadays, of course, is online. So, and after the meeting, you feedback us on your contribution. Next slide. So this, as you can see, this is the evolution of patient involvement at the European Medicines Agency since its start at 2008. So you can see it was only protocol assistance, meaning, as you might remember that I mentioned, for orphan drug designated. And then in 2013, it started for all type of drugs, not only orphan drugs. And then later on with the health technology assessment as well. So you can see that there has been an increasing on patient involvement within these activities. And next slide, I would like to show you the impact of patient engagement at the EMA. So as you can see here in the graph, we can see the areas of where patients have contributed the most. Usually it's on the population. So which population should be included or excluded, the inclusion-exclusion criteria, the endpoints of the trial that should be sick, the quality of life of the patient. And then here I wanted to highlight some percentage based on the EMA annual report. So 20% of the scientific advice protocol assistance letters to the developer has changed thanks to the patient input. And also 53% of the cases has the patient input has resulted in further reflection to the EMA. And here I wanted also to highlight one comment that we received from an EMA scientific officer, that thanks to the patient input in that specific case, he said that that gave us additional reassurance for the treatment of that drug in that case, that it was in a high unmet medical need, and what that urges to make it available to the patient and for the to have it available for the patients. So next slide. So all this has been compiled now within a paper, and here I guess this slide will be shared with you so you can access to the paper, the added value of patient engagement in early dialogues at the EMA, and this is example of the scientific advice as a case study. So here is the analysis of the patient input in scientific procedures. So they have compiled 125 responses from patients, and they have analyzed these answers, and almost 80% of the patients understood what was expected from them. They feel that they were able to provide input, and they feel that the comments were taken into account. So overall, it was a positive experience for the patients, but they highlighted main barriers as the complex information that they receive. As I mentioned to you before, there are no lay summaries available for patients, and also the short deadlines that the EMA works. So usually we have only kind of 1 month from when we receive the request from the EMA to the identification of the patients, and then another extra month to prepare for the meeting if there's a TC, or to get the comments in writing. Next slide, please. So here are my take-home messages and some considerations for you as patients. So either maybe this process can seem daunting and very long and tough, but please rest reassured that patient input makes a difference, that you are the expert of your disease, and here you have the support of the EMA and also of the EURORIDS to go through the relevant points of the questions, and also to get prepared for this meeting. Some other considerations that I would like to share with you is that, of course, patients and carers are expert on their disease, but not always they have a scientific background, and that's linked to this complex information that they usually receive patients. So you are volunteers, and we all know that, and you don't have the same support as the clinical experts that are involved in this type of procedures, and that's why the EMA Public Engagement Department, the Scientific Advice team, and also EURORIDS provide support. And also, very that I mentioned also in my previous slide, a very key thing to have into account is that patients participating in the EMA procedures are bound to confidentiality. So everything that's been discussed during these meetings cannot be disclosed to anyone else. And also that you are bound to conflict of interest policy. So that you should be aware that if you are in contact with other companies, you might not be able to get involved with some of the regulatory activities. So with that, I would like to thank you for your attention, and here you have my email address if you have any further questions, and looking forward for the panel discussion. Thank you, Dan.
That's great. Thank you, Maria. Absolutely fascinating. And it's really interesting to hear all the work you guys have been doing on the engagement side. And again, a lot of this is done, which I think we need to give more visibility to as advocacy groups to our communities as well, to see it's not just us fighting for our patient communities. There's lots of people doing it on a broader sense. So I'm just going to invite back in a few of our previous speakers to join our final panel. as everyone comes back in. So this panel, I know we're running a bit tighter on time, so maybe cut it down by a few minutes, but really I want us to talk about the challenges of getting that right health information and what we can do about it. So I know that, Rebecca, you gave a really interesting talk about the amazing work you guys are doing. Since you were established, have you seen the rare disease community's understanding of where to get that information shift? Are they now accessing it in different ways? I'd be interested to hear what you've experienced.
Yeah, I think it has since we started. I think when we first started, one of the problems that we saw was that really most of the way that families were getting their information was maybe, if they were lucky, a leaflet from their consultant. If they weren't lucky, it would be a printout from their consultant that had come off some website that wasn't necessarily in language that they could understand. And of course, some were really sent away with nothing. I had a really interesting call quite early on. I met with NHS innovation team to talk about the role that Rare Revolution could play in being a resource that healthcare providers could use to signpost families to as a method of information. And really frustratingly at that time, the people on the board that I met with, bearing in mind this was an innovation panel, their opinion of patient groups at the time were that they were a bit over the top. And so they didn't send their patients there because they couldn't guarantee the quality of what patients were going to find. They took a very hands-off, oh, well, we can't trust in that information approach. And I am pleased to say that I do think that is changing now. I think more and more healthcare providers are turning to support groups as a first port of call on diagnosis. I don't think it happens as much as it should happen, but I think we are starting to see a shift there. I also see a big change in how much information patient groups are providing. I mean, the quality and the wealth of information on their sites is incredible, you know, especially considering given some of the human and budgetary resources that they're faced with. They really do have excellent materials for all stages, and even materials that are designed for healthcare providers, which is great. I also threw this out to the wider team to see what things they had found, and I think what we're also seeing is a big move into social media, where young people in particular are choosing to get their information from other people's lived experiences rather than kind of formal educational materials. It was really interesting to see the comments from Chelsea and Katie, who very much said, you know, there's a big move away from you know, using young people engaging with patient information resources and actually just turning to places like Instagram and TikTok, where I think those platforms in particular have empowered young people to share their lived experiences. And that's where a lot of people are now turning to. So I think it's a positive, but I think the challenges are that for patient groups, manning multiple platforms is a big undertaking. It's a lot for them to manage. You know, it's not just Facebook now, it's Twitter and it's Instagram and it's TikTok and it's LinkedIn as well for some, and tailoring that content for each channel. Also, it's really noisy. So how do you have the bandwidth to grow an audience to make sure that your stuff is being seen over and above stuff that's clickbait or not as appropriate? So I think it's positive, but it also has its challenges. But I think there's been a real progression in terms of how much information there is and where people are getting it from.
That's really interesting, because I think about it in terms of yourself, Gisela. So when people reach out to speak to you, and you have to do a lot of signposting to the right information, and you've taken innovative approaches on how you do that. Do you think other companies will or should adopt how you are distributing information about the charities and the studies you're doing?
Yeah, I definitely think that's really important. It's not only on study information, which I think is for companies as we are very important to bring in a proper way to patients. It's like, I think Toni said it, there's so much going on Google that you never know which information the patient finds or gets. So I think a company has an obligation to really set up new programs for patients to learn more, not only on study, but also in a later phase on adherence or on other projects which could be beneficial. And I think the good thing of social media and websites, etc., is that you can tailor-made it more, and people can really find the correct information. So I think that other companies can easily copy or influence this as well. Yeah.
So on an advocacy level, we're very fortunate in Europe to have EURORIDS as someone we can all be members of, because they do a lot of work that we are not set up to do, especially as rare disease and small organizations. I know, Marie, you touched on some of the work you've been doing, but I know there's a few other initiatives you're working on at the moment. It'd be great to hear maybe a little bit more about one or two of those for the community.
Yeah, sure. So as I mentioned, besides the role of engaging patients in AMA and in different activities, we are also involved in different public-private partnership projects. So one of it is the Connect for Children, which is a private public IMI, so funded by the Innovative Medicines Initiative. So we have partners from the industry, the companies, the pharmaceutical companies, also researchers and hospitals, and we are working all together to create a pan-European clinical trial network and to enhance pediatric drug development. And in this project in concrete, our role is to bring patients in the center of the project, and patients are involved in the review of the protocol. So in that project, there are 4 clinical trials that are run into different national hubs, so in hospitals, and then there are 4 private companies clinical trials running there. So we involve patients in the protocol and in the whole process. We are also we have done some trainings to patients on pediatric drug development, also on how drugs are approved, but also on how patients can be involved, as I mentioned kind of today as well. And also in the project, how they can be involved. There's a special tab in the IMI Connect for Children website for patients. They can register in that expert database and then can be involved in different activities. And one of our main key goals is that we are developing, or we are being part of what we call multi-stakeholder meetings. So we are running this year the 3rd multi-stakeholder meeting. So what we are trying to do is to kind of organize this meeting every year. So we focus on one disease area where there's a lot of development. So a lot of pediatric investigational plans, meaning that companies or researchers are investigating in that area, but there are no treatments out of. So kind of it fails at some point. So what we are doing is we are bringing all the experts in the table. We are bringing researchers, clinicians, patients, companies in developing in that area, and we share the unmet needs all together, and we propose a strategy to move forward. So this year, for you to know, it will be focusing on pediatric diabetes type 1, but on the challenges of the access to medical devices. And for us in the rare disease community, it's kind of for us, we don't have access sometimes to the drug, and in diabetes type 1, you might think they have a lot of treatments, but in some countries they don't have access to some medical devices that are key for young patients. So we'll be that focus. So I think we are working on different things in different initiatives, and this one actually will finish, I think, in 2024. So we still have 2 years to do more activities, and I encourage everyone to go and have a look at the website.
Cool. Thank you, Maria. Very interesting. Yeah, we can pop those links into the chat, and people can access them. So I just wanted to hand over to Emma we mentioned briefly about when we first got into contact, those emails you received, and that whole process of navigating the diagnostic journey. So the way people are now signposted is very different. But do you think we could be doing more? And if we should, what should we be doing at that?
I think it's really getting the information to the people who come across initially, who families initially have to deal with. I think that's where it's needed. As I say, I was given some information on a printout, which is nothing I hadn't already read, and I didn't have confidence. They didn't give it to me with confidence. It was just a piece of paper. They didn't know anything about what was on it. That was it, really. Yeah. So there was I didn't feel like I was under anyone's wing until I'd actually contacted the CATS Foundation. I didn't, till that point, I felt very lost. Yeah, so I think that initial, the initial diagnosis, there needs to be, the information needs to be right there and handed over with confidence and a bit of information, maybe, rather than, yeah.
That's really interesting, because I suppose for Diana, do your families encounter this sort of problem still? Because I know obviously on the state level it's different, and for us we have the country issue where each country has a different ways how the health systems distribute information, how the doctors are culturally distribute information. Some don't want you to know anything, some want to give you a lot. The UK, for example, we're naturally very pessimistic people, so we're kind of like, this is what you're going to know, this is what's going to happen, that's it. So it'd be interesting to know kind of the challenges you guys are facing.
I mean, I have to say, sometimes even with the states, it feels like different countries, quite honestly. And depending where families are, if they're more in a rural community, they may not have access to information about, patient groups or what the disease is. We've had families contact us calling from the parking lot after a diagnosis where their doctors printed something off Google and then sent them on their ways to process. So I find now, though, we spend, like I mentioned earlier, we spend a lot of time listening, and we'll curate information depending on the family. I also find engaging with other patient groups too, and patient organizations, I learned so much, even today, listening to all of you, taking notes furiously, and I think that's really important in the information we share with families, is listening. What are others doing too? So I hope that answers the question.
Yeah, it does. Thank you, Diana. It's really interesting. And as we've said before, the challenge for us is to try and get this information out there in a uniform way, but culturally sensitive as well as language sensitive, which can be difficult. So I was going to wrap it up. I don't know if there's one more thing you all want to contribute before we finish for the day. So I'll put someone on the spot. Rebecca, I'll put you on the spot. One last key thought for the day would be great.
Yeah, I think as well, especially in terms of that diagnosis information, something that the XP clinic out of St Thomas's did, I think quite well, was they did follow-up phone calls that were 2 or 3 days later, because there's such a lot of information to take in those appointments and the shock of it means that you don't, the dog, he's been quiet all this time, he's just decided to chirp in. You don't always take it all in. So it's about making sure that the information, not only that you've got the information, but that you've got it at the right time, and that you give people an opportunity to revisit it and come back to you with questions.
That's great. Thank you. Anyone else got any final thoughts they want to share?
No. Thank you.
Thank you.
Thank you, all of you.
I was thinking that I think there's a thing that should be improved, and maybe now I'm like, and this is my personal comment, but I think that for patients, and I received these comments a lot, is on regarding the clinical trials. So I think we need to try to find a way, and I think also in the US and in Europe, the portals are very difficult for patients to navigate, to understand where there's a clinical trial, where's the site, the recruitment. And I think that we need to make these public directories kind of easier for patients to find, also in their national languages, at least in Europe, because we have this big country, different languages, but also to be user-friendly, accessible for always for people who have impaired vision. So we have to have accurate but also updated these clinical trials portals available for patients. And also, if the top would be to have like to subscribe and then you receive updates on this. But I think that patients are really struggling on this, and yeah.
That's interesting, because I know that the Duchenne group in the UK launched a research portal that was trying to do something similar to make it specific for their condition. So it's an interesting approach.
Yeah, I think. I think it's a very important comment, because it's sometimes difficult. Also, clinical.gov is not so patient-friendly for patients or even for us sometimes. So I think there, and also when you're doing focus groups with in-company focus groups, patient groups, you can discuss how what would be the best way to disseminate the information? So this, I think it's a very good comment. Yeah.
Very good. Great. Well, thank you, everyone. Obviously, thank you for joining the final panel. I'm just going to bring Bea in today, who's going to be closing up the conference. So I'll leave you all to enjoy your evening. So Bea, I'm going to hand over to you.
Okay, thank you everyone who has participated in this second part of the conference. Really, we have listened to really interesting sessions and discussions today. I want to just recapitulate from a few things I've been taking notes about. First of all, Toni Mathieson start to talk about global concerns, how this issue about the adherence to clinical trial is really a global concern. In spite that every country and every continent has its own regulation, but it is really a global concern because we have a lot of more access to information, and the medicine and the science is really progressing, but it is still something to address. And those challenges regarding the information for the community, not only the information, but the effective communication of that information. And in this, of course, the role of the patient organizations is absolutely key. Also, Riliang made an interesting session about clinical trials, and what I rescue from this session is something that she started saying at the beginning of her presentation about the benefit for the patient. We need to keep in mind, the industry needs, and the doctors and the researchers needs to keep in mind that, of course, we need to progress in science terms, but we need to keep the benefit for the patient. And this is something that has come up in all the sessions, in the way of saying how important it is to maintain the patient and his family into the center of the system. And of course, the other important part of her speech is how important is not missing parts of the studies, how important is to make the patient understands that it is very important to follow up on the process. So we need to think about how to prepare patients, as I said during my session, because I think this is crucial, not be able to end a study that has begin with a lot of promising possibilities. Alex from Cognitant, it was also very interesting what she said about how to educate caregivers about a study, a clinical study, and the challenge, the incredible challenge that it's supposed to recruit participants to take part in the studies. There's a lot to understand still about the studies, and this is something that we must to take our role to grab it, to make really a difference compared to past studies. We are in another time now, so I think this is possible, but there is a lot of work to do. Well, Gisela, of course, as a patient advocacy, she is really interesting to hear Gisela. Someone in the comments was saying that he didn't know that this figure of this person of a patient in company patient advocacy exists. In fact, I don't think there are many of them in all the companies. Gisela has explained very good about how many times this is not only a person but a team. But I think it is important to make families understood that companies and the industry are each more time getting worried about this and taking measures for this. And very interesting how she explained that this is a two-way street, and how to incorporate all the patient insights in a cross-functional way under settled standards, but making team with transparency above everything. Well, then we had Diana and Emma. I want to leave Emma for the end because she said something that really touched me. Diana, I love what she said about at the beginning about this is the best job she ever dreamed about, because this shows how motivated patient organizations are. This shows how a vocation, when a vocation is really addressed, we can do a lot, and this is something very important, and that we can see in most of the patient organization. It is very important to have professionalized all the team, but it is very important to transmit this vocation, and it is very important to be able that if that charity has been set up by a family and they take all the work to professionalize it, the vocation that oriented results, but also emotion for get things well done is so important, and the importance of sharing experiences too. I recommend everyone to go and visit the Red Revolution magazine. Thank you, Rebecca, for explaining how it was the beginning. It is so interesting to know who is the team that is behind it, and that nice team that you and your sister have been able to build up. I think it's lovely to write about rare diseases. We can see in a lot of family that they have the impulse many times to write, to there's a need to express how do you feel when you have a kid affected, and to read other testimonies, not only have the experience of meeting other families, of going to meetings, but also to have the possibility of reading about them in your intimacy. I think it is very important, and it's an important thing that we can have this kind of publications, to have this kind of testimonies also, like together with the rest of information that you treat. But I want to rescue that. Well, also Maria from New York, it is of course very interesting to hear always. This is like a big umbrella for all the rare disease patient organization in Europe. Is a reference to us, and it is really, it plays a key role in bringing the patient's voice into decision makings. And sometimes this is the complicated stuff for us to understand, not only the disease, not only the possible scientific research going on, but also the regulatory side. Sometimes patients forget that there is a regulatory side, and that you cannot forget to take this into consideration when you think that if there is a cure or a treatment for a disease. So to mentorship the patients, how to participate in these activities, I think is something crucial. And to end, to this is like the sum up of all that we have here, but I want to rescue two things that Emma Murphy from the CATS Foundation and Rebecca also has said. Emma has shared her valuable testimony of how she found out the diagnosis of her son, and I think that every experience is a gold treasure. I think that really we don't only need all the scientific and biological data from these diseases, that is of course at the forefront always, but we all also need to hear these testimonies. We need to know how a family faces to navigate in the uncertainty of a rare diagnosis, and it is great to know that a patient organization can be there to open that terrifying door to say to you that you are going to be, you are not going to be alone during the process. There were some people in the comments expressing how isolated you feel when you receive this diagnosis, and I think this is very valuable from Emma testimony. So thank you for that, because I think it's very brave, and for you to be now as a family officer is very valuable, and it's like God that we have all that experience convert into professionalism help. And also I want now to close this day one of our European conference with the words from Rebecca. Rebecca talked about that necessary opening talk, that necessary sense of belonging to a community that we face when we receive the diagnosis of a rare disease. And she said that hope is finding community. And I cannot be more in agreement with you, Rebecca, because I think that what you said, that you don't need to be terrified at hope, is something crucial. My personal view on this, my personal experience was that hope is a word that turns out to have many different meanings. And this is something that it's important to translate to our families when you have a disease that has not a cure or a treatment, that hope is not only that your child is going to be cured tomorrow. Hope means a lot of more things. It means to belong to a community. It means to be able to give some legacy from your child's life, and that you and every parent, every mother, every caregiver has a lot to tell about his experience that really turns out into a lot of information and help for research progressing, and for, in this case, adherence to clinical trials and to make it better. So thank you everyone for these interesting sessions, for sharing all this information. Tomorrow we have the second days more focus on which treatments are now under clinical trials, and so we wait to see you. We look forward to see you tomorrow, and we will say goodbye for now with a video. So thank you, Dan. If you want, you can play the video now. Thank you, everyone, and see you tomorrow.
It takes a spark to start a fire.